morning, ladies and gentlemen. We are waiting for a quorum. We will be starting in the next 5 minutes. Thank you for your patience. morning, everyone. Come on, I don't hear the energy. I will just marathon talk. Good morning, everyone. There we go. This is a joint committee of the Committee on Public Safety and Health and Human Services. I'm your co-chair, Councilman Curtis Jones, and we are to review resolution number 240703. Ms. Steck, would you read the title of that resolution?
Resolution number 240703, titled Authorizing the Joint Committees on Public Safety and Public Health and Human Services to hold hearings to investigate the effectiveness and potential expansion of mobile mental health units administered by the Department of Behavioral Health and Intellectual Disability Services.
Thank you so much. And would you take the roll so we can establish a quorum?
Chairman Jones.
Present.
Chairwoman Ahmad.
Present.
Vice Chair Lozada.
Present.
Councilmember Harity.
Present.
Councilmember Bass. Councilmember Driscoll. Councilmember Brooks. Councilmember Gaudier.
Present.
Councilmember Landau. Councilmember O'Rourke.
Present.
Councilmember Thomas. And Councilmember Young.
Thank you so much. A quorum has been established to review this resolution. I want to open up by saying that this is like in public service. If you live long enough and if you watch and pay attention close enough, you see progress, that things actually do change sometimes for the better. But it is always important for every now and then for authors of legislation to go back and take a look at, well, how are we doing? How can we do it better? And to give kudos where appropriate and to give constructive criticism where there's not. And also, at the end of the day, if there is a budget implication, to at least know about that request. So with that, we are taking a look at, in my opinion, the community response, but also, unbeknownst to some of the people testifying here, but we tried to work it out in advance, the co-responder response. And my colleague, I didn't mean to traumatize her this morning, I talked about the evolution of this response due to an incident in her district with Walter Wallace. And I'm gonna let her speak to that and that situation. But ironically, we have a 7 a.m. every Monday morning roll call with all of the high schools in the western part of my district, meaning West Philly. And we talk about public safety and all of those things that go into making sure our scholars, our babies, get to and from school safely. And sometimes we have to protect them from themselves, from others, and even the system. And in this conversation, one of my principals, who will not be named, said that he had an incident that week where a 240-ish pound African-American man who suffers from some intellectual disabilities found out in class that his parent had died. And in that process, had an episode. Started tearing up the room. He was distraught. And when he went into the room being called to assist the teacher, the student pushed him. And at that point, I'm on bated breath, like what happened next. He said he refused to call the police because that student's grief would not be taken into consideration and possibly be the result of some intervention that wasn't warranted in the continuum of response to a situation. This is very similar to what happened to Walter Wallace, or could have happened. But thank God, he de-escalated the process to the degree that he was able to cope with the situation peacefully. So with that, that's the purpose of it. So every now and then we want to look back and see, yeah, we had this great idea, 50,000 feet in the City Hall. But how's it working on the ground? What can we draw from it to make it better? And with that, I want to recognize my colleague from the 3rd District.
Thank you, Mr. Chair. As you point out, the tragic situation with Walter Wallace Jr. Crystallized for me certainly why we needed mobile crisis units, why we needed to have skilled mental health professionals to respond to people when they're in the midst of a crisis. I'll never forget that day and what happened. In watching later on the body camera footage, it stood out to me that that interaction was 41 seconds. I know that it was 41 seconds because I'll never forget. And certainly Walter Wallace Jr. had a knife, and certainly he was behaving erratically, but I will never forget his mom and his neighbors screaming to the police that he wasn't a threat, to have kindness and patience with him, but we know what ultimately happened. And the reason why we need a more compassionate response than what we saw that day is that this was devastating for everyone. It was devastating for the family who will never have their loved one back. It was devastating for the neighbors. It was, I believe, devastating for the policemen. And watching that video after the shooting happened, there was this sort of, what did I do moment. And of course, it was devastating for our community. It was the second time in a matter of months that we had civil unrest in the community in response to that police shooting. So this is very important. It's very important to have a skilled mental health response when we are dealing with a mental health crisis. And I can only imagine if we would have had that on that day, on that October 26th, that we might have had a different situation and we might have had Walter Wallace Jr. alive. And so it's for that reason that I joined with Treatment Not Trauma for several budget years to advocate for millions of dollars to the city's mobile crisis unit program, but we have to make sure that it's operating in the way that we need. We can't, it's not just about allocating the money during budget, it's about making sure that we are implementing this initiative well, because as we've seen, it's life or death. And so thank you so much for having this very important conversation.
Thank you, Member. Thank you, Member Goodyear. My co-chair, Nina Ahmad.
Thank you, Chair, and good morning, everyone, and thank you for being here for this really important hearing. As my colleague, Councilmember Gautier, just outlined, how do we very carefully decriminalize mental health responses? And I think we have enough examples of how we haven't done that, but I think this pathway, which all of you have worked so hard for, is actually makes us very hopeful. And I just echo everything that has been said, that it is about transparency, accountability, because we have to respond to our community, right? They have to know what's going on, and we have to be able to tell them the resources we invested in this space is bearing fruit. And one of the things I have found in my 1 year being on council is our constituents just don't have enough information of all the services we provide, you provide, right? And part of that is being a cheerleader for the resources you are providing for our community, and being that conduit to say change is happening. We just said we want to celebrate good, the things that are working. But we can't celebrate them if we don't know them either. So I think making those changes, making sure we have a way to communicate and show that their tax dollars are being used effectively and compassionately. So thank you all for all the work you do, and I look forward to this hearing to give us much more information and see where we can be helpful, as mentioned in the budget process as well. Thank you.
So I'd like to, for the record, recognize Member Brooks and Member Landau, who are also, pardon me? Oh, and Member Brooks would like to be recognized. Member Brooks? And Member Landau. No. Oh, she's that way.
Thank you, Chair Jones, for bringing us together for this hearing on mobile crisis units. When we established this program in 2022, it was a major step forward for mental health access and violence prevention for families here in Philadelphia, and it has become a model for cities across this country. 3 years later, I stay confident that this program has been invaluable to people here in Philadelphia. I heard Councilmember Gautier speak on the incident that we all remember 4 years ago with Walter Wallace, and I don't want to rehash that, but we realized it was a mental health crisis. And these mental health crisis teams, they grew out of pain and outrage of a tragedy, but also came out of it was hope that this will never happen again. So now when we have families going through a crisis, we can call 988 to access trained medical health providers instead of involving police. And in most cases, counselors are there to provide care and resources over the phone. But in some cases, the crisis requires an in-person response, and that's where the mobile crisis teams come in handy. These teams have been bringing care and expertise directly to people's home and the community, and they have been saving lives. I want to share a brief story to highlight how I've seen the mobile crisis team at work. Sometime after the program is launched, I saw a young man in the midst of a mobile health crisis. He was in public, unclothed, and my mind immediately went to Walter Wallace Jr. Thankfully, someone called 988, and the mobile crisis team arrived to provide care and support without involving police. That's one day I can see our city in action when legislation works for the people, and it was a feel-good moment. Each day, over 200 Philadelphians are reaching out for mental health support. As the awareness of 988 grows, the need will continue to grow, and we must be prepared to meet that need with fully funded, fully staffed crisis response teams. Through the budget process, we need to look at how we can continue to expand this life-saving program. Just as we commit to supporting firefighters and EMTs, we must commit to supporting mental health first responders who are saving lives for the lives of Philadelphians when they're in a crisis. So thank you so much, Chair Jones, for bringing this together, and I look forward to hear from several witnesses today.
Thank you so much. Member Landau, did you want to speak?
No, just...
Did it? No? With that, can you, Ms. Stack, tell us the first panel to testify?
Interim Commissioner Marquita Williams from DBH IDS. Also available for questions will be Dr. Tiara Pritchett, Kenny Sherlanke, and Dr. Lisa Colton.
Thank you so much for what you do. Please come up to the witness table. Thank you so very much. So if you will state your name and begin your testimony, we can begin.
Good morning. I am Dr. Marquita Williams, Interim Commissioner for the Department of Behavioral Health and Intellectual Disability Services. Good morning, Chair Curtis Jones, Chair Nina Ahmad, Vice Chair Lazada, and members of the Joint Committees on Public Safety and Public Health and Human Services. As I said, I am Dr. Marquita Williams, Interim Commissioner of the Department of Behavioral Health and Intellectual Disability Services. Joining me today are Kenny Sherlanke, Senior Director of Crisis Operations, Dr. Lisa Colton, Director of Crisis-Related Services, and Dr. Tiara Pritchett, Deputy Commissioner of DBH IDS for Administration, Finance, and Quality. Thank you for the opportunity to provide updates on the expansion of Philadelphia's mobile crisis response services under our Crisis 2.0 framework and to address the considerations outlined in Resolution number 240703, introduced by Chair Curtis Jones. This resolution calls for an evaluation of the effectiveness, challenges, and potential expansion of mobile crisis response teams, which have become an essential part of our city's behavioral health infrastructure. Today, I will provide an update on our mobile crisis response efforts. Philadelphia's crisis services system has undergone significant transformation through the implementation of the Crisis 2.0 framework in the past 4 years. This framework includes several components. 1, the expansion of our community mobile crisis response teams that now provide services citywide 24/7, the city's first behavioral health urgent care center, the addition of a 5th crisis response center in the city that is located in West Philadelphia, and the expansion of the Philadelphia Crisis Line that includes the 988 National Suicide and Crisis Line Initiative, which has received national recognition. Starting with our crisis mobile response teams, in 2022, we contracted with 4 providers, Elwyn, PATH, Consortium, and JFK, that manage up to 29 community mobile crisis response teams, 24 hours a day, 7 days a week across Philadelphia. Each provider is responsible for a geographic region, and they can respond and deliver immediate supports in the community for individuals experiencing mental health crises. This critical resource helps to reduce the need for law enforcement involvement when an individual is having a behavioral health-related crisis. Between January 2023 and January 2025, approximately 14,302 dispatches were recorded, and that number continues to grow. On September 3rd, 2024, we established the city's first adult behavioral health urgent care located at 3125 North Broad Street.
Can you stop a minute?
Yes.
How many responses?
14,302 dispatches.
Continue, please.
Yes. On September 3rd, 2024, we established the city's first adult behavioral health urgent care, located at 3125 North Broad Street. This urgent care center marks a critical step in providing additional capacity to our city's overall crisis system and is a resource that provides people with same-day crisis services without the need for appointments. In the first 5 months of operation, between September 2004 and January of this year, the Behavioral Health Urgent Care has conducted 1,133 service encounters, reducing the need for a more acute crisis intervention. Additionally, DBH IDS opened a 5th Adult Crisis Response Center in West Philadelphia at the Hospital of the University of Pennsylvania, HUP Cedar, in September 2023, which has increased our capacity to address the growing needs for immediate crisis evaluation services in West Philadelphia. Finally, a significant part of our crisis system capacity building efforts is the expansion of the Philadelphia Crisis Line, also known as PCL staffing. In 2022, in preparation for the national launch of the 988 Suicide and Crisis Lifeline, our city's crisis response infrastructure significantly expanded to increase capacity to provide access to immediate crisis supports for Philadelphians. Thanks to the funding from City Council, DBH IDS was able to expand PCL staffing to significantly meet the anticipated needs of the callers to 988. PCL now handles over 6,000 calls per month, providing telephonic crisis intervention, clinical consultation, and seamless dispatch of mobile crisis teams when in-person support is required. Additionally, the collaboration between 988 and 911, which co-locates 988 counselors in the 911 radio room, has led to a 36% increase in warm transfers of behavioral health calls from 911 to 988 during this same period, ensuring that individuals in crisis receive the appropriate mental health care swiftly and effectively. Our efforts to enhance the crisis system in Philadelphia has been complemented by a comprehensive 988 public awareness campaign, promoting the 988 Suicide and Crisis Lifeline and educating the public on available resources. This campaign is ongoing, and it includes partnerships with local media, sports teams, and community organizations. This awareness campaign has significantly increased the utilization of crisis services and contribute to a better public understanding of mental health supports. I'd like to now spend a little bit of time sharing with you how we have operationalized and monitored these efforts and where we see that the system and resources put in place are excelling and where there have been challenges that we are actively addressing. The effectiveness of our mobile crisis team is measured through a set of key performance indicators, including response times, community stabilization, and community feedback. I would like to highlight some of our most significant achievements. The primary goal of mobile crisis response teams is to stabilize individuals in the community wherever possible, thus minimizing the need for hospitalization. Mobile crisis disposition data shows that over 50% of dispatches resulted in no need for urgent or emergent services, and that these cases were resolved successfully in the community. This means that the crisis was resolved, allowing individuals to remain in their homes and communities with appropriate supports. The rate of involuntary commitments, also known as 302s, has decreased to 17%, reflecting a shift towards voluntary community-based care. Additionally, voluntary evaluations at crisis response centers, or CRCs, are around 6%, reflecting improved crisis resolution at the community level. DBH-IDS works to make strides in reducing response times for our crisis mobile community response teams through targeted strategic enhancements. The addition of GPS-enabled dispatch technology has allowed the PCL crisis line to continuously track and monitor the location of all mobile crisis teams. This real-time capacity helps identify the nearest team to the caller, resulting in faster dispatch processes and improved response times. Our goal for CMCRT teams to arrive on the scene is within 50 minutes of dispatch. This is the benchmark aligned with best practices nationally for crisis intervention. Recent data indicates that with the expanded capacity and our improved technology, our median response time has been reduced to 50 minutes citywide. Our 4 CMCRT providers include Elwyn, PATH, JFK, and the consortium. And while they have all worked at meeting the 50-minute best practices benchmark, JFK and the consortium teams have operated consistently within the 50-minute response benchmark. It is important to note that the consortium CMCRT team also has provided mental health supports to individuals sheltered in our city's warming centers during January. DBH-IDS also conducts customer satisfaction surveys for people served by CMCRT, and the surveys conducted between June 2022 and May 2024 found that more than 70% of respondents rated their experiences as highly satisfactory, highlighting the team's helpfulness, professionalism, ability to de-escalate crises, and provide compassionate care. We continue to monitor customer satisfaction closely, sharing results with providers to ensure continuous quality improvement. While our mobile crisis response teams have seen notable successes, there are some areas that require ongoing attention. There is high turnover among frontline staff and leadership. and this remains to be a persistent challenge affecting response times and continuity of care. We've observed slower response rates during high call volume periods when a provider is experiencing staffing changes or when dispatches are made outside of a provider's region. To address response time challenges, particularly during peak hours, we have supported providers in adding bridge teams. The bridge teams increase the number of available teams during the high volume periods. With the $3 million increase in funding for FY24 from City Council to enhance our crisis system, we have provided increases to provider budgets for the addition of these bridge teams, which have proven effective in reducing response times during busy periods. These additional shifts have helped to decrease delays in dispatch and arrival times, especially in the busiest regions like West and Southwest Philadelphia. Overall, ongoing support will be needed to sustain these efforts and to achieve a stable workforce. There is also a need to continue to ensure standardized trainings across providers. We want to ensure that there's a standardized crisis intervention training program for all mobile crisis team staff to ensure consistent, high-quality care across all providers, and we will need consistent funding and resources to implement the highest quality of care for the people we serve. We also want to improve the current process and our reliance on law enforcement for transporting individuals under involuntary commitment. Police transports are not ideal, as police officers are not trained behavioral health professionals and not equipped to deal with the variety of illnesses they may face. Establishing a dedicated behavioral health transport team would alleviate the burden on law enforcement, streamline the process of involuntary commitment transports, and improve the overall experience for individuals in crisis. So in conclusion, implementation of the Philadelphia Crisis 2.0 framework has strengthened our behavioral health crisis system, providing timely, effective, and compassionate care. DBH-IDS remains a committed partner in this endeavor, dedicated to providing a trauma-responsive, equity-driven crisis response system for the residents of Philadelphia. We look forward to continuing to collaborate with City Council and other stakeholders to further refine these crisis services. Thank you for your continued support and for holding these important hearings. We look forward to working together to enhance the sustainability and effectiveness of Philadelphia's mobile crisis response services. My colleagues and I are available for your questions.
So does that mean no one else is testifying at this point?
Yes, this is
it?
Yes.
Okay. So let me first say that a part of my job description, part of all of our job descriptions, is to listen for a living. And I listen. It is always good when I'm thinking about questions and you're answering them automatically in your testimony. That is always a good feeling for me and probably many of my colleagues. It says that your preparation and testimony was comprehensive. So kudos to you.
Thank you.
Let me ask you, where do we stand by way of national models? Where I don't think we were the first to do a co-responder model, but I'm thinking we were right up there with some of the groundbreaking cities that have done this. Do you have a?
Yes, we weren't the first, but we were certainly early adopters of the model.
And when we talk about 14,000 responses, how do we match up to other cities?
You know, I'm not sure about the call volume for other cities, but I can get that information to you.
Because, you know, every now and then it's good to be able to say to our colleagues in other places that good things come from Philadelphia.
Absolutely.
Can you describe for us some of the general types of responses, and when you get there, so from the easiest to resolve to some of the more challenging to resolve? Give us a sense of those out of that 14,000.
Okay, absolutely. I'm going to bring in Dr. Lisa Colton and Kenny Solanke.
Please state your name for the record.
Hello. Oh, hi. My name is Kenny Solanke. I'm the Senior Director of Crisis Operations for DBH-IDS.
I'm Lisa Colton. I'm the Director of Crisis-Related Systems for DBH.
Okay.
So an example of an easy-to-resolve crisis that a mobile dispatch could respond to would be, this is actually somebody, the team gets there and the individual is not there, or the individual refuses support. So that's an easy one. It's an easy fix. Or the team gets there, they provide the evaluation and the assessment, and they see that there's a need for this individual to go to the CRC, and there's an agreement that this person will go to the CRC, transported by the mobile team. Those are fairly easy. But then you have instances where, in some cases, they arrive and people will tell them, I have a gun with me, or we have a knife, or there is a complicated issue with a family. And I can have Lisa give you more specifics in terms of the kinds of difficult dispatches that could take longer than the median, which is about 30 minutes. This could take maybe an hour.
But I also want to add that for
Pull
the
that
simple
mic a
dispatch...
little closer to you.
Oh, sure. For the simple dispatches, where perhaps the individual is gone, or refuses to speak, the mobile team will still meet with the family or whomever the caller was. So this would be a third-person call, probably. So it's not as if they just drive away. There's still an intervention that occurs, and ongoing support can be offered to those families. For more complicated situations, so we could have someone who is what we call a barricade, someone who might be in their room with the door closed, suggesting that they don't want people to come in. It's unclear what's in the room, if the situation is safe or unsafe, if police support is needed, something like that. I'm trying to think. We have parents who really are frightened of their children having police intervention and the child is refusing, or even an adult who, an older child, an adult child. So there could be some negotiation that goes on for some time with the team. It might even include coming back, offering a service. Well, okay, so for now things are settled. We'll wait till morning. We'll come back and re-engage, that kind of thing. So it could be an extended intervention.
So I remember going over to the 911 center with my colleagues, but one of them was Mayor Parker. And when we went over there and looked at that and saw that kind of difficult kind of balancing act, help me to understand, usually is it the police that respond first and then the mental health component? How does that work?
So
or do they go together?
If the call comes through 911, then it is the police who respond first, even if the call is transferred over to us, and then a mobile team can also respond. Sometimes police request a mobile team when they're on site to a call that hasn't come to 988, but if the call goes first to 988 and we do not see any safety concerns, the mobile teams will go first.
So it's also my understanding that there is a log that lists if Member Harity's, I live with Member Harity and I have ongoing crisis problems, that number is logged in, and so there's almost an alert that Member Jones might be going through crisis. How does that work?
For the on the police side, you mean, for 911?
Yes.
So yes, there are frequent callers to 911. We're talking upwards of 200 calls a day. Those go to a particular detective, and we work with that detective to discuss what the caller's saying. We try to engage the caller. The trouble is if the caller refuses to be engaged. So we have had different examples where we've sent teams out to those calls. We've also engaged the co-responder team. Sometimes callers to 911 want police, right? They're frightened. They're calling about something that's scaring them. So the co-responder teams can be incredibly helpful. So we've had that experience. We've also had this detective go out with some of our teams because she often communicates with these people that call multiple times to 911, so she can be a liaison, the goal being to try to engage them in some kind of additional intervention that's not calling police.
You mentioned that there are how many units available? 39, I think? the number?
There are 4 providers, and they each have a team per shift, including the bridge teams. So when you add all of those shifts together, there's about 29 teams operating in a 24-hour period.
And usually you are deploying them based on volume of calls? How do you determine that?
Yes, we're deploying them based on whoever's closest to the caller. We have a GPS-enabled capacity to see where the teams are. So if I'm calling from City Hall, whoever the team is that's closest to me, which will probably be JFK, will be the team that would dispatch to my call. So even though they are regionalized, we have Elwyn out, in the part of Philadelphia they're in, and Path out in the Northeast, and JFK's here. We really want to focus on getting to our callers as soon as possible. So whoever's closest to that individual is the team that we're going to dispatch.
Finally, are those teams stationary or are they mobile going around? How does that work?
That's a very good question. They're stationary, but if there's let's say, Team A and Team B, if she's on a call and I am on another call, when she's done that call, we don't have any calls to dispatch. They may have some downtime so they can go to their office, use the bathroom, or have a lunch break, or whatever the case may be. But more often than not, part of the reason we decided to do mobile GPS-enabled technology is to ensure that as you're wrapping up a call, we're giving you another dispatch close to the vicinity where you are. So you're not running back to your office just to come right back down to where the caller is. But we have one of our providers here who can speak a little bit more to how they manage their teams and dispatches.
Feel free to bring her up.
Now, I thought they were testifying.
Okay.
Caroline?
Okay.
They're testifying later, yes.
All right, they will testify later, I take it. Okay.
Yes.
Member Goodyear?
Good morning, Commissioner and team. Thank you so much for your testimony today and for sharing wonderful information about how you all are implementing the mobile crisis unit model. It's important work, it's groundbreaking work, and we appreciate you. But it is work that we want to grow and make even better, and in the spirit of that, I have some questions. First, I think we're all aware that there have been some issues with the contract for the consortium, which serves a large portion of my district. And in fact, 1943 in my council district is a zip code that has been utilizing mobile crisis units the most. And so I want to ask about the plan to ensure continuity of care for all of the patients that have been served or that are being served by the consortium right now.
Councilwoman, obviously this is a very complex situation.
Absolutely.
There's a lot of parts involved, and so we're not at liberty to talk about it here today right now, but the continuity of care for the clients is our #1 concern as well.
Okay. Can you talk about the kinds of things that we're considering around the continuity of care for
Absolutely.
those patients?
So we're considering the level of care that the clients are enrolled in and what providers, in the event that we needed to move forward, we would be able to transfer them to. So making sure, as you said, that clients don't go without services.
Do we feel some level of confidence that there are enough providers and enough teams to serve those patients, or do we feel that we would have to grow the network in any way?
At this current time, we believe that there are enough providers.
Thank you. I consider these to be emergency services. I consider these to be life-saving services. I hope that you all do too. Mm-hmm. Given that, do we feel that a goal of 50 minutes for a response time is adequate?
Well, the national standard is 50 minutes. We are trying to get under that as best we can. We are really proud that we have reached that 50-minute medium. We would love to get it even lower, and that's what we're consistently working on.
I seem to believe that we've had conversations with DBH, IDS, in a prior administration, granted, where the goal was to get to 30 minutes. Do you have any information on why we've sort of left that goal to the side for a 50-minute goal?
I have to own the 30-minute goal. When we wrote the RFP in 2021, we thought that Philadelphia was small enough, and if we had a provider in each of the different regions, that of course they can travel. I don't think what we anticipated was traffic and the distance and some of the things that happen, just in the course of the day that will make it very difficult for providers to travel from one point to another. So 30 minutes is a dream. There is no mobile team within the country that's able to make it to their destination in 30 minutes. 50 minutes, an hour, 2 hours is more the norm. But we're still working on reducing that 50 minutes to, let's say, 45. If we get to 45, then I'm still trying to go down. And how do we get there? By expanding the teams, by having more boots on the ground.
I want to commend you for being ambitious and having a 30-minute goal, even if nowhere else in the country is reaching that. And I would imagine that with the thousands and thousands of people that we've served, it's probably a good dream for us to have. Is there a way that you would be able to let our council know how we would ever reach a 30-minute goal?
So we just had our recent team expansion. Each provider added a bridge team just this past fall, summer. And we want to see a whole year. What does that look like? I think it's gotten us to 50. So how many more teams would we need? Do we need another bridge team to layer? So at the busiest times, we have not just the day and the evening and the bridge. So each provider will have maybe 3 at those core hours. Do we need 4 teams? So maybe that's what's going to do it for us. But mind you, as ambitious as we are, real life happens. So you have a provider that has a team member who's sick, or they're on vacation, or something happens. Right away, that team is off the grid. We can't use them. And so those are the kinds of things that impede our ability to have those core teams functioning 7 days a week at that critical mass. So yes, adding more teams will be the answer to that, I think, and barring all sickness, vacation, and people leaving the jobs to go do something else, because that's the other problem. There's a huge turnover. This is very difficult work. And we want to recognize them as behavioral health first responders.
Can I ask that this budget cycle you submit to us a plan for how we could get down to 30 minutes and what that would entail?
Sure.
I know we've been talking about the consortium sort of offline. I would ask to continue those conversations so that I can understand in more detail what the continuity of care looks like for those patients. And then I have one last question. Could you talk more about the types of calls and scenarios other than suicidal ideation that are being transferred to 988 from 911? And then can you also speak about, vice versa, about what kind of calls are being transferred from 988 to 911?
Sure. So one of the functions that the mobile teams do is that they can go out and facilitate a 302 petition with a family. So those kinds of calls would be transferred from 911. They would come to us. They wouldn't require any kind of a police intervention. Additionally, someone asking for information about the system, questions about, what do I do? My husband is not feeling well. I don't know how to negotiate this system. Or maybe a passerby who sees someone in a wheelchair who looks like they need support. Nothing overtly dangerous, those kinds of questions. More, inquiring for support, for assistance, that kind of thing.
Slight follow-up. Is this data that we're tracking? And if so, are you able to provide that to the committee?
So data from the police and the police system and our system are not the same. So we have to ask them for that kind of data.
Can we ask them?
But we can ask.
Yeah,
All
for
right.
sure. Yeah.
Thank you so much. Thank you, Mr. Chair.
So softer calls.
Thank you, member. Chair recognizes Dr. Nina Ahmad.
Thank you, Chair. This is extremely informative. I have a few questions. One is the high turnover, right? We know this is an issue in terms of retaining people, and it's a high-stress job. So can you speak to, if I'm correct, what are the reasons for this high turnover, and what the solutions could be to this high turnover, and how do we compare to other cities where we have this model in terms of their turnover?
I can say that because 988 is across the country, there are 3 requirements for 988. You need to have a 24/7 988 call center. You need to have a 24/7 mobile crisis response team and 24/7 crisis response or crisis stabilization center. So what we're doing in Philadelphia, we're ahead of the game since 2019, 2017. Other states are now trying to catch up. And as we have our national 988 meetings, we're all coming up against the same thing. It's really difficult to get people to do this job, especially when we're looking for master's level clinicians to be crisis response specialists, and we're paying them barely minimum wage. So I think the problem is, and this has to be from a national to a state perspective, we have to elevate these roles as behavioral health first responders so they can get paid accordingly. Thanks to you, we were able to increase the budgets for our providers. They were able to provide salary increases for the existing staff and then bring on board the bridge teams at a higher salary. But I think we can do all of that. My concern is there's also this idea of safety. It takes a different kind of person to do this job. You have to feel very comfortable and confident in your ability to engage and use your clinical skill set to help people de-escalate crisis. Not everybody is able to do that. And I think after some time, some people just burn out and they want to do something else. So a lot of the things that we focus on when we meet with our providers is this idea of wellness, not just from the provider side, but also from the crisis call, the 988 counselors that we have that are constantly hearing these calls. So I think it's ensuring wellness, providing some value to the job and increasing the salaries of the people that do the work.
So thank you for that. It's clear, obviously, salary is important, but the conditions of the job too. It would be very useful to do an economic modeling of saying investing in this space downstream would save us so much money, right? And I think if nothing else moves people, if we could set up some paradigm where we can then allow us to make the argument of why investing here is so important. So I would love to, see what you're able to give us. Maybe we can employ all these big institutions who love to do this work, because that would be a value add locally, statewide, and nationally, right?
Absolutely.
We have to make that value proposition. The second question I had was about de-escalation training for police. Do you work with the police to see, I recall Dr. Marquita Williams saying that normalizing what the training looks like across the board from your provider side is important. But also, are you the people who are training the police for de-escalation, because some calls, because of violence, potential violence, they get called. Who handles that, and how do we assess that?
Sure. So the police have a social worker named Erin O'Donnell who does the CIT training to all the officers. We do have different members of DBH-IDS who participate in that training. And then we on the crisis line specifically have regular clinical conferences with the CERT teams, with the co-responder teams, to talk about specific cases. We also have a very fluid relationship with them. They will call us on site if they have a question about something, about how to do something, about what to do, where to go. So we have a very nice relationship with the CERT team and with the officers on that team. And we don't have direct training with the precincts, but we do communicate with them. I'm actually working with the airport right now around their police and looking for support with their homeless teams.
So the reason I ask is one for standardizing the response from all the law enforcement. And you mentioned they have one person training a certain group, but this is, I think our police force would really benefit from the entire force, particularly those on the beat, to get this level of training, which could be something your department can offer for a price, right? And that could be, I'm just saying, it's all moving the money around, but this could be something that could be very useful to have a standardized level of training depending on who, what type of police officer that is, and to have more than one person doing a handful of people. It just seems, again, this would be reducing police hours, this would be reducing violence on the job, this would be so many things. So another economic model to show your intervention with police can result in long-term stability in our communities. The last thing I wanted to ask was, in terms of, where you see this work going in terms of improvement, in terms of what the data was shared with us, how do we track, and Council Member Gautier, sort of asked this question as well, how do we follow people past this encounter that, you respond in a mobile crisis way, so that the long-term mental health of whoever you intervene for has a warm handoff. We have, now we have the model for people with substance disorder to, have a long-term, go into like a year at the wellness centers, right? So it would be lovely to see what we do for others who have mental health issues that cause the crisis team to show up in the first place.
Right. We are in the process of creating our follow-up team within PCL. So individuals that are suicidal that call 988, they get a call back. Depending on the level of severity of the information we get, they can get a call back within 24 hours, 72, 48, whatever. And that can continue depending on what that person needs. So that gives us a sense for, are they following up with the recommendations, the referrals, and the community-based services that we're providing. On the mobile team side, after that crisis intervention, there is an expectation for that provider, for the team, to provide follow-up within 72 hours, just to see how Kenny's doing. I set up that appointment for you. Are you going to be able to make it? Is everything okay? Is there anything else we should be thinking about or doing as we're continuing towards this path of recovery? So those are the two follow-up options we have. If we were to take it even further, if these individuals have CBH insurance, we can make sure that, yes, they are connected, this person did show up for that appointment, and we can see the trajectory from that call all the way through disposition. Yep. Right. It's a little harder for our constituents that don't have insurance, but we can still have a way to figure out where they're going in the system, because with CBH, it's a claims, right? So the provider was paid for something, so we know they went. But I think we have to continue to work on what would that look like for individuals that are not CBH eligible, but we're also connecting them to services.
Those are the people who probably need it the most,
yes,
who do not have insurance coverage of any kind. So this is great that you're already proactive in this space and you're collecting data, because that was what is going to be really useful for us to say that your follow-up services, and we compared that to years past and see the difference in what happens to our communities. Again, a great model for us to use in terms of budget allocation. So I would appreciate that kind of feedback and data to tell us how we can advocate for more of this. So thank you so much for all the hard work. Appreciate it.
Councilwoman, to your questions about crisis intervention training, we have a team member here with us from our Behavioral Health and Justice Division who can give you some more information about that. Shakira Gillette, one of our Associate Directors in Behavioral Health and Justice.
Wonderful.
Thank you. Please come.
Thank you.
Come up and state your name for the record and respond.
Good morning, Shakira Gillette from the Department of Behavioral Health, and I just have some information on our CIC trained officers. The CIC program has actually been absorbed by the Philadelphia Police Department, but the Department of Behavioral Health, we used to spearhead this training. And the CIC program initiated in 2007, and since that time, 4,708 Philadelphia Police Department officers were trained in crisis intervention services. Class 149 was in February of 2025. So this program has been doing phenomenal. It was doing so well that the Philadelphia Police Department decided to absorb the program from us. We still provide behavioral health support, which means we still partner with the program to be a behavioral health expert in the room.
So Member Ahmad's comment about modeling and measuring is critical, because if it ain't measured, it ain't managed. And we can't fight for additional funding if we don't know what our rate of return is. And so it's kind of hard to figure out. It's hard when you prevent things, because that's what you do often. You prevent arrests, you prevent hospitalizations, but we have to figure out in that modeling, how much is that worth to taxpayers? So with that, I recognize Member Harity.
Thank you, Chairman Jones. Since I'm the only Irish guy here, I'll say happy St. Patrick's Day, everybody. Only Curtis Jones could get this Irish guy here on St. Patrick's Day. I don't know if he knows how much of an accomplishment that is. But first, real quick, just a real quick one. What's the starting salary for one of your team members?
Which one, sir? Or
Well, I would.
for the mobile crisis
What's
team?
the start? How many are on each team?
There are 2 individuals on the mobile crisis team. There
And
is
what's
a crisis,
the starting salary for those 2 individuals?
The crisis specialist is anywhere between 55 and 59, and the peer specialist is anywhere between 45 and 49. At least that's what we see in the budgets. We don't get to dictate what the providers pay. We just give them a range for what we think is best.
Okay. All right, that's good. That was a nice quick one. What do you think the success rate has been on decreasing police intervention in the behavioral health episodes and situations? Are we kind of getting that away more than if you guys did say that already, I apologize, but.
No, I think we are getting away from having the police involved in behavioral health crisis. There's been really minimal, I want to say, and I don't want to lie, but the numbers are low enough in 2027. Thank you. So this is what I was looking for. So for example, in 2024, one provider had only 3 individuals that were detained by police. And again, that's out of hundreds of dispatches. Another provider had just 1. We had another provider that had 3. So in total, it was about 10. That's really, really low. Because if you think about not having these teams.
That's what I was just thinking. That was my follow-up.
Well, so I'm just talking about 2024. So the numbers we gave you was like from 2023 up until January of 2025. But for this police involvement in behavioral health crisis that the mobile teams were involved in, we had about 10 in 2024. So the way I see that is if we didn't have these teams, how much higher would those numbers have been? So 10 had to be, the situation was so risky, right, that the teams needed to call law enforcement to support their intervention.
Yeah, I think those numbers are really good. All right, do you believe as this program expands, it will help take the burden away from the police department?
That's our hope.
Because that's actually the goal, right?
Yes.
The goal? All right, so that's the goal. And then how are we advertising the 988 system? Because I'm a big, we as a city, we do a real bad job of telling people about all the great stuff and great services that we can provide. Just curious of how you're getting that information out to the public.
We are trying.
I mean, because apparently you are.
Yeah.
If 14,000 people knew to call 988.
Right. Yeah.
you
So
know.
in since 2022, we received some SAMHSA grant funds just for 988 education and awareness campaign. So we've had PSAs on television. We've had ads on the radio, iHeart, everywhere, KYW. We have had partnerships with our sports teams, Go Eagles, where their playbooks, we have an ad in there. We have a partnership with the Sixers where they have mental health awareness night. It's all about 988. We just had one in January, and we have a lot of resources and cards that we give out. We have partnered with the school district to create swag for kids. What I would love to do at some point, if not this year, next year, we still have a little bit of SAMHSA money before they take it away, is to work with the school district to see if they're willing to have 988 on the back of ID cards. A lot of states are doing that. So all of the school IDs have 988 on the back of it. I would love to do that. Our community wellness and engagement units, they go out into the community and give out information. But you're right, we have to do more. We just don't have enough money for it. But with the little we have, we are spreading and stretching the funds.
SEPTA supports us as well. There's 988 signs in all of the SEPTA stations.
I'm a big supporter also. It's always all over my personal and my government site. Mental healthness, it affects everybody.
Yes.
So we need to get that stigma away, that is very outdated. You know what I mean? The God's honest truth is most people, after speaking with a professional, usually are okay.
Yeah.
And we need to make sure that they're available more often. The fact of the matter is that we don't have enough of those professionals. There's a crazy statistic that came out a few years back where we have one child psychiatrist for every 10,000 kids in Pennsylvania. Philadelphia, we're a little better in the numbers because we're a big city, but statewide, it's 1 per 10,000. That's just crazy. All right, thank you.
Thank you, Member Hardy. Before we go to Brooks, Rue Landau, and then O'Rourke. That's the order. I'm trying to keep track. Quick question. Is your funding in jeopardy based on the new federal administration? Is there how does that trickle down payment happen? So based on the federal administration and situation, is there any jeopardy to your funding, or is it directly from the city of Philadelphia?
It is directly from you. Thank you so much.
Thank goodness.
We are so grateful. But I have to be honest with you, a lot of other states are not so lucky. So the federal government, through SAMHSA, gave some grants for 988 capacity building. So a lot of states are relying just on that money. We have you, and we have Health Choices. So the money they're giving us, we're just using for 988 awareness. We're trying to spread the word on 988 because that's part of what you're supposed to use it for. So whatever happens with SAMHSA would not impact us. We just will lose the grant that they've given us through 2026. But other cuts will impact, I think, Medicaid, which impacts our work. That's where the problem lies.
Got it. Member Brooks?
Okay. So I want thank you guys so much for this amazing work. I have been following not just our own mobile crisis center, but all over the country. I've been to Portland to see the Portland response team and a couple of other programs, and I'm always very proud to see that we're, holding our own, and your testimony has been really amazing, and it makes me feel good just to hear that things are going as planned. I have kind of two questions. One, to add to Councilmember Gautier asked for some more specific information about scaling up. Can you make sure we have some budgetary numbers for that? Because I don't know if she specifically asked for like how much it's going to cost. I know she asked like how many more staff would you need to do this, but we need to know the cost of that.
Yes.
Especially in light of what Councilmember Jones just asked. We don't know what's going on. Like with the federal government, everything is on the table. That's how I feel. And the rest of the team, my colleagues have asked so many really good questions. So I have one about DBH IDS. They do support work for people in mental health crisis that are heavily reliant on the trust in the community, community groups, including groups like Treatment Not Trauma. So they're here today with the treatment. Great. And they have been instrumental in setting up life-saving programs and expanding funding. They are the ones who kind of put the fire against us and gave us the charge to make this happen. So how many meetings with community groups like Treatment Like Trauma have you guys held within the last 6 months, and what groups have you met with?
So we have a community advisory board for Crisis 2.0 evaluation. That's a quarterly meeting, and TNT is part of that. In the beginning, when we were starting this Crisis 2.0, we had a learning collaborative that started in 2021, the end of 2021, through 2020. It was about 18 months. They were part of that group. But since we went into implementation, it's really been about ensuring we're getting teams out, we're getting the service rolled out, and we have not had specific meetings with Treatment Not Trauma. But I think they're part of a 911 community.
We have a meeting monthly that Treatment Not Trauma attends, a community meeting in conjunction with public safety.
And
we can only take testimony from the table because it has to be transcribed. So if you shout out who you are, your name, maybe that'll get to our, what's your name? Your name.
You're talking about the group?
Yeah.
Oh.
Who
They
spoke?
mentioned them.
Yeah, but, all right. Okay, we'll continue our testimony this way.
yes, Councilwoman, first of all, thank you so much for all of your support. We really appreciate how you have advocated for us. But in addition, we have had some meetings with Treatment Not Trauma. Specifically, I've met with them, with some of my team members. Whenever there's a need or a request for a meeting, we have that. So we've actually met with them twice over the last 6 months.
Okay, so I was just like that you guys kind of set up something to more, in our current era that we're in, I know that advocacy and government goes hand in hand. And I think as we move forward, if you guys can make sure you kind of meet more regularly to make sure that everyone's on the same page with moving forward to ensure that we can continually fund and support the work that you do, because like they were the advocates that got this moving. I would love to make sure that things are continually moving smoothly. So if it's quarterly, can we just, or, because I'm not really clear, because I think it could be
Different meetings.
There are a couple of different meetings that are happening, yes.
So if we could have something just like more streamlined, so it's clear that everyone's voices are being heard and we can continue to grow this program, and you guys can continue to do the great work.
Absolutely, thank you.
Thank you, Member Brooks. Member Landau?
Thank you so much. I agree, adding my voice to the chorus, appreciate your work so much, and appreciate the innovative ways in which you've gone forward to solve a very serious problem here in Philadelphia. I have a few questions for you. First, I might be missing something, so I want to dig down on something. We've talked a lot about calls that go from 911 to 988 and from 988 to 911. I've gotten an understanding now a bit more about when calls are going to 911, when they're looping you in for 988. I'm not getting a full understanding of when calls come to 988, when are you looping them in When are you looping in 911, and under what circumstances? And also, I believe we heard that you've only had 10 police interventions in about a year or so of interacting with including 911 to 988. But again, I want to get a fuller understanding of when you're calling them and when they're coming out.
So in terms of when we at 988 would call for 911, that would be for an active rescue. So what would happen would be the call taker from 988 would stay on the line with the caller, and we have a Teams chat, right, of all the callers. They would ask, I need help, I need someone to call 911, this is the situation. So someone else would call 911 and request immediate police support. So
under what circumstances would you do that? What would the caller have to say to you at 988 for you to use your Teams chat to have a colleague call 911?
I'm standing on the bridge, I'm going to jump. I'm on the ledge. That kind of rescue. Okay. Something, yeah. Or someone who had a weapon. I have the weapon and it's at my head. Now, the call taker would continue to support the caller and try to get them to, take the bullets out of the weapon, put the weapon down, that kind of thing. But you'd also need police to be coming to the home for support.
From your data, it seems that you get about 6,000 calls a month, a lot. Thank you so much for all that you do. Approximately how many of those, or what percentage of those, rise to the level of you including 911?
I don't have an exact number. It is not a regular, thankfully, not a regular occurrence, not an unknown occurrence.
Do you track that data?
Yeah, we actually, so calls received from January to 2023 through January of 2025, for example. These are the calls to 988. It's 147,375. That's the number of the calls in 2 years and 1 month. Mm-hmm. The warm transfers from 911 to us is 4,146. Now, from us to them, I think we're going to have to.
We just have to get you
the number. We have to get the number.
Okay,
that's all.
I would love to know
that. We'll do track how many they're sending to
do.
us because we think that's really important, that they're not getting in cases that are behavioral health in nature and doesn't need 911 involvement.
Okay, thank you. I also wanted to ask more about your dashboard. I'm the chair of the tech committee, and so is there a plan to update the mobile crisis public dashboard? It was last updated in May of 2024, and will you include this data that I just asked you about the inclusion of 911 and 980?
So the data was taken down from our 988 website from the request of city law because we had monthly data, which was a violation, so they wanted us to make that annual. That data has been updated. It is now back on the website. Oh, I'm sorry. I thought I was loud. Ooh, big difference. Yes, so the data is back on the website now, and it shows annual data. It's no longer by month. And we can definitely ask City Law if it's okay for us to share the 911 call transfer data as well.
Okay. Thank you. I think that's it for the moment, and thank you.
Thank you, Member. And finally, Member O'Rourke.
Thank you, Mr. Chairman. Most of the questions really have been asked, so let me just begin by saying good morning, Interim Commissioner Williams and team, and thank y'all for being here with us today. I just want to say that your testimony has been, as Councilman Jones lifted up, so comprehensive and thorough at a time that I think that's so important. We are in the midst of budget season. We've heard a lot about the challenges with our federal situation, and your ability to provide us with this sort of information as we listen really prepares us and helps us to know where we need to allocate funds in this time. I really appreciated the reference that you made, especially as we hear echoes of this line about strength or peace through strength or force and things like that, making us stronger, kind of being a theme throughout the country in our governance. To hear you say that timely, effective compassionate care has made our system stronger is something I think ought to be emphasized. The idea that compassion makes us stronger is something that I think should be emphasized and funded through the roof. So again, thank you for making that point heard loudly. I also want to acknowledge the work that has been done to get us here on this issue over the last 5 years by members Bass and Driscoll and Gautier and Thomas and others. And just as importantly, I want to echo the shout out that was lifted up already and thank the advocates and the groups like Treatment Not Trauma for helping lead us in a better direction in the wake of that unfortunate death in the situation with Walter Wallace. Let me just say I do look forward to hearing even more throughout the course of this hearing today. But I just wanted to ask a quick question about data for CERT outcomes. What data do you have for outcomes for CERT dispatches, and how many dispatches, if you have it, are actually resulting in involuntary commitments?
So the CERT data is provided by the police. I'm looking at Kurt August, who is the holder of that data. Not sure if maybe I can invite him to speak on that.
Chairman Jones?
Can you please approach the witness?
Oh, I'm sorry. Shakira might have. I apologize. BHAD could speak on that. I'm sorry.
And state your name for the record and respond, please.
Shakira Gillette, and I'm sorry, may I have that question again?
Yes, I'm just asking about what data you have for the outcomes of CERT dispatches, and from that data, how many of the dispatches are actually resulting in involuntary commitments?
Okay, great. So from December 1st of 2022 to January 31st of 2025, there was a total of 1,775 encounters for CERT and 2,192 follow-ups. Out of the 1,775, only 19 of those individuals were arrested. As far as 302s, there was 568 involuntary commitments. And then there was also, as far as individuals who said that they wanted to go into the hospital, there was 356.
356 that wanted to go in?
Yes.
What was the date again? You said December 1st, 2022 to when?
December 1st, 2022 to January 31st, 2025.
January 21st, 2025. Okay. Thank you very, very much.
You're welcome.
On behalf of Member Lozada.
Yes, thank you. Councilmember Lozada had to step out. She had a question about, you mentioned the teams are stationary and then you deploy when the call comes in, right? Do they travel in their personal vehicles, or is it like your van or some other?
They have vans that were included in their budget that they purchased for mobile crisis transport.
And she has a separate bill around an issue about providers in her district, which is why she was asking this. And then she had a follow-up question about classifying these folks who are responding as first responders, because that would then exempt them from the law that she was looking at. So I just wondered, how are they classified now, so I can give her that information?
They're not classified. I think I'm the one that is advocating for calling them behavioral health first responders. And I don't know what that would require to make this not just for Philadelphia, but for Pennsylvania as well, so that the staffing, the training, and everything is standardized across the state, but particularly across the Commonwealth of Philadelphia.
That's wonderful, because that changes the whole, how they're viewed in terms of our city, state, and the nation, because it elevates the role of needing this service, and that mental health is part of health, and any crisis in our health spectrum should be addressed, right?
Exactly.
So, okay, I will definitely convey this information to her. Thank you so much.
Thank you.
That's a good point, because they're doing the job. She should get the designation. With that, there are no other questions on this panel. Ms. Stack, who are the next group of folk to testify?
Lindsay Eshelman and Rebecca Stewart.
Thank you for your testimony.
Thank you.
One of the colleagues, one of the things that I heard about this potential hearing is that when we call people to testify, we need to be more welcoming, because they were kind of apprehensive about what we were coming at them for, what did they do wrong. No, every now and then we want to acknowledge that you're doing things right. That goes with these hearings as well.
Yeah, absolutely.
Thank you. Please be seated. Thank you for your patience. Please state your name for the record and begin your testimony. Good morning, still.
Okay, I will start. My name is Lindsay Eshelman. I'm the Deputy Director of Crisis and Residential Services for John F. Kennedy Behavioral Health Center.
Good morning. I'm Tanara Stiles, the Clinical Supervisor for JFK Crisis Services.
My name is Rebecca Stewart. I am on faculty in the Center for Mental Health at Penn, co-leading the Crisis 2.0 evaluation.
Okay.
So first, I'd like to thank the committee for having us here today to share about the services we provide to citizens of Philadelphia. I'm going to start by discussing how we promote safety and improve client outcomes. I'll then discuss how mobile teams fit into Philadelphia's crisis continuum, and will conclude by sharing how we ensure staff are appropriately trained and adequately reflect the populations they serve. I'll then turn it over to Tanara, who will provide some real-life examples of dispatches that our teams have handled. Sorry, just need to make sure I'm close to this. So how we promote safety, how do we do this? So first, by meeting people where they are. So we'll go to wherever the crisis is occurring. So this could be in a home, at a shelter, in a library, on the street. We're never asking someone to come outside and meet us. We're going to them. So this really increases comfort. Second, by prioritizing confidentiality. So teams arrive and we're wearing plain clothes, so we're not dressed in a uniform. And we'll identify ourselves through the use of badges such as this. Some teams might have small insignias on their shirts, but we're not overtly announcing to passersby or to neighbors who we are. We also preserve client confidentiality by asking where the consumer feels comfortable sharing with us. So if we go to a library, we might ask if there's a free room that we could speak to the person in. If we're in the home, we might ask where they feel comfortable sharing with us because they might not speak freely in front of family members. So one team member could speak with the consumer in crisis, one team member could speak with the family. We can make sure that everyone's heard, that we're gathering all the information simultaneously, and providing the best outcomes. Lastly, we promote safety by creating safe spaces. So we really want team members to notice nonverbal cues, both their own nonverbal cues and the nonverbal cues of those that they're serving. So this means we want everyone to have open body language. We don't want them crossing their arms. We want them to notice if maybe a consumer is clenching and unclenching their fists. This might indicate to us that we need to disengage, give the person more space, or try to redirect them. Lastly, we train them in active listening. So we don't only want to hear what the consumer is telling us, we want to ensure that they feel heard as well. So all of these factors contribute to us creating safety for both the clients, the communities, and the teams that are out there. So improving outcomes, we achieve this by providing person-centered approaches. So each of our interventions are tailored specifically to the person we are meeting. So because the city has expanded the number of teams providing services, this allows us to spend time thoroughly gathering information, harnessing natural supports, and truly valuing client input. And by doing this, we provide meaningful solutions that reduce reliance on crisis response centers and promote the usage of and linkage to community supports. So now where do we fit in on Philly's crisis continuum? So we see ourselves as the second layer of support, with the Philadelphia Crisis Line being the first layer. And they do an excellent job at providing resources and resolving many of the less acute crisis situations. But there are occasions that necessitate an in-person intervention. So this might be a health and welfare check. There might be circumstances where a delegate is unsure or unable to determine if the information presented is domestic in nature or mental health related. There are also instances where they just can't de-escalate someone over the telephone, or maybe they don't feel comfortable creating a safety plan without having eyes on the person first. So once the teams receive a dispatch, the primary goal is to get to the scene as quickly as possible to avoid any changes in the circumstances. So the faster we arrive, the higher the chances are that the person in crisis, A, hasn't left the scene, or B, hasn't changed their mind about receiving services, or C, the situation hasn't changed, necessitating some other type of intervention. So as DBH-IDS previously said, our new dispatching program, Behavioral Health Linked, has improved response times by offering geolocating technology that allows dispatchers to see which team is closest to the crisis. So once teams arrive on scene, they identify themselves and begin the assessment and information gathering process. So in addition to implementing evidence-based techniques, teams utilize existent healthcare and community resources that are integrated into the crisis continuum as a means of preventing need for hospitalizations or CRC referrals. So similar to emergency departments, we triage needs based on acuity, allowing us to expedite certain supports. So for instance, a client that's seen by a JFK team can be referred to our fast track system. This gets them an intake appointment within 72 hours of service, and in acute cases, it can be same day. So this cuts down the wait time for an intake appointment from potentially months to a mere few days. Additionally, as DBH-IDS referred to previously, the new Marikey Walk-In Clinic can provide great treatment options. So if a team notices that someone's experiencing a crisis because they don't have access to their medication, we might transport them to the Marikey Walk-In Clinic where they can receive a bridge script. So if they do have current services, they just don't have an appointment in the near future, they can get a bridge script for 3 weeks. Marikey Walk-In Clinic can also write new prescriptions. They have peer support specialists, case managers, short-term provider treatment options. And if we do notice that someone needs to go to the Marikey Walk-In Clinic, we will give them a call in advance to let them know that we're coming, and we also will provide them with a warm handoff so they know what the situation is. So in sum, we're kind of a second layer of support. We can provide expedited linkage to needed supports, and we also do on-site stabilization plans. So if we don't need to bring anyone anywhere, we'll at least create a stabilization plan, and then we'll do follow-up to ensure that they're following that stabilization plan. Finally, how do we ensure staff are appropriately trained and adequately represent the populations they serve? So our staff consists of registered nurses, certified peer specialists, licensed mental health clinicians, among others. So when screening for appropriate candidates, we not only want to see credentials that look good on paper, but we also look for qualities that translate well into real-life application. We need individuals that function well under pressure, have the ability to multitask, and also think outside of the box. Once hired, supervisors will conduct scenario trainings to give staff sort of a broad view of different crisis situations. New staff will also shadow teams to gain an understanding of how they function, what they do, and who they serve. So all staff also receive onboarding and ongoing training in areas such as suicide prevention, motivational interviewing, trauma-informed therapy, cultural competency, among others. All staff also receive ongoing supervision by a master's level mental health clinician. Additionally, the ongoing support of this program has allowed us to hire supervisors that are in person nearly 24/7. And so for those few hours where we don't have an in-person supervisor, there's always someone that's on call. So this allows teams to have extra guidance through complicated situations. Also, if a critical incident occurs, they'll have access to a supervisor for debriefing services. And this is really important because, as DBH-IDS had mentioned, there is a high degree of burnout in this field, and so having that supervisory support is essential to staff retention, and it's also critical to the goal of achieving compassionate care to the communities that we serve. So in terms of diversity, staff provide support by drawing on both lived and clinical experience, so we ensure that staff live within the communities that they serve so that they can draw from that knowledge base when providing assessments and building rapport. So JFK ensures that teams know, hear, and recognize the communities they serve. And with that, I'm going to turn it over to Tanera to give you some examples of dispatches.
Thank you.
Good morning again, and thank you for allowing us to speak in front of the council.
State your name again.
Tanera Styles. Due to our teams being diverse, well-trained, and supported, as well as fully integrated into the crisis continuum, they excel at on-site stabilization. An example, for instance, is where a team went out to a personal care home to assess a resident who was agitated and restless. The team was able to de-escalate and redirect the behaviors through brief interventions, counseling, as well as being able to identify that resident's triggers, which specifically had to deal with family dynamics. The team was also in a place to provide staff with insight as well as support to help them mitigate any future escalation of behaviors in that situation. Also, they were able to make contact with that individual's therapist to move their appointment up to the same day, as well as passing off pertinent information to help with that day's session in accordance to what that episode incurred. The intervention that used by the team was also able to help avoid the use of this crisis response center, as well as providing support with personal care staff, and then avoiding the possible termination of that resident's agreement with the home. Another occasion, the team responded to an individual that was in crisis experiencing a suicidal ideation after they had a very recent and serious attempt. The team built rapport with that individual, offering understanding, compassion, and been able to identify and let the individual express their unmet needs, fears, and anxieties going forward. They worked with the individual to develop a comprehensive safety plan that included natural supports, as well as providing follow-up through JFK in connection with our services. Through this interaction, the team once again was able to avoid the use of a crisis response center and allowing the individual to stay home, maintain their autonomy, and allow them to willingly agree to benefits and services.
Thanks again for allowing us to share, and I'll turn it over to our researcher.
Hello, my name is Rebecca Stewart. Thank you for having me, and also to DBH-IDS for including me. Closer, really? I'm a clinical psychologist and assistant professor at the University of Pennsylvania. Today I'm speaking on behalf of my co-investigator, Molly Candon, and our team at the Penn Center for Mental Health. We have been tasked with evaluating Crisis 2.0, which Dr. Williams described so well. It's a citywide initiative aimed at improving the experiences of Philadelphians having a mental health crisis, which includes an expansion of adult mobile health crisis services, which is why we are here today. In short, I can report to you that mobile crisis services in Philadelphia are decreasing the need for expensive inpatient care, which results in cost savings to the city. We already know that mobile crisis services work. One way that researchers measure their effectiveness is if mobile crisis services help individuals de-escalate and connect to community-based care while avoiding other costly and potentially traumatizing outcomes. The effectiveness of mobile crisis services, especially in decreasing hospitalization rates while facilitating access to community-based care, has been demonstrated in other cities for many years. For example, a rigorous study in Atlanta from 25 years ago found that mobile crisis services resulted in a statistically significant reduction in psychiatric hospitalizations compared to crises handled by police. A more recent study from Connecticut concluded that mobile crisis services reduce the use of emergency departments, another very expensive level of care. Researchers have also found that most individuals in crisis do not want police involvement and prefer trained mental health teams. Mobile crisis services do just that by connecting individuals in crisis to the appropriate expertise and minimizing criminal justice involvement. While we're only in the very early stages of our Crisis 2.0 evaluation, we have some exciting preliminary analyses to share with you today. One of the biggest challenges in evaluating programs like mobile crisis services is constructing a comparison group. That is a similar group of individuals who do not receive mobile crisis services, so we can compare their outcomes to a group who did not receive mobile crisis services. Using administrative data from here in Philadelphia, we compared Medicaid-enrolled individuals in crisis who called 988 and received crisis services in 22 and 23 to a group of Medicaid-enrolled individuals in crisis who called 911 and received care from ambulances in 2018 and 2019, before we had these teams. We found that half of individuals who used ambulances ended up in a psychiatric hospital within 30 days of their encounter, compared to only 1/3 of individuals who used mobile crisis services. This amounts to a 34% reduction in inpatient care, and based on our estimates, the decline translates into roughly $5 million in cost savings to the city over 2 years. Our evaluation team is doing more than just looking at administrative data to understand and improve the delivery of mobile crisis services in Philadelphia. We've convened a community advisory board of experts along the crisis continuum, including Philadelphians with lived experience. We're surveying staff, talking to this retention issue of local agencies to better understand the barriers and facilitators of providing high-quality mobile crisis services safely. This year, our team will interview Philadelphians who use crisis services, including adult mobile crisis services, with the hope of pinpointing areas of strength and opportunities for improvement. We will be thrilled to share the findings with you in the future. To close, I commend the city for providing these much-needed services, and I extol the Department of Behavioral Health and Intellectual Disability Services and Community Behavioral Health for pursuing a rigorous evaluation of its rollout and for their commitment to continue to improve mobile crisis services. On a personal note, I'd like to share, with her permission, that of my co-investigator, Molly Candon. A decade ago, she had her own mental health crisis. Like many Americans, she resided in an area without mobile crisis services. Her episode escalated, and she was involuntarily committed to a psychiatric hospital before being connected to the community-based care that helped her. We are committed to this work in part because we believe she would have had more effective and less traumatizing care had she been served by mobile crisis services. Our team at the Penn Center for Mental Health is grateful to support Crisis 2.0, and I'm happy to take any questions. Thank you.
Thank you all for your testimony. For the record, when I cross my arms like this, it's only because I'm cold. So, don't want you reading into anything that is not there. But couple of questions. One, what percentage of the people that you are engaging are senior citizens? I heard that you have actually gone to facilities to have to intervene. What percentage does that represent?
So I don't have an exact number. I can give you one at some point, but I would say it's probably about, if I just had to guess, maybe 20% of our callers, maybe 25%. It kind of fluctuates depending on the month, so I could also provide you with data that's over a few months span.
And conversely, what percentage of your respondents are juveniles?
So that's actually a question that I couldn't really answer because we have specific children's mobile crisis teams. So JFK is an adult mobile crisis team. We will handle children calls if there's an influx of those at one time, but we only get about maybe 2 or 3 a month in that capacity. But I could certainly pass that along to the child mobile crisis teams to give you some data on that.
Yeah, I think those are important demographics that we need to kind of codify. Your 72-hour referral process, does that pose a problem sometimes? When does that kick in versus immediate care?
Right. So we typically will refer someone to an intake within 72 hours if we're able to stabilize the crisis at that time and we feel comfortable with an on-site stabilization plan. And again, we can do same-day referrals in urgent circumstances, so that is a possibility. But we continue to do follow-ups, usually within 24 hours. So the person that we do make a referral for will have a follow-up call the next day.
And finally, your vans, do you transport people in those vans? And if so, describe for me the interior of the van.
So we do transport individuals in the van. They're really just typical vans. There's nothing that's adjusted inside of them, with the exception of one of our vehicles that does have a divider between the front where the team is sitting and the back. But that's just one of the vehicles, and team members kind of can choose which vehicle they feel the most comfortable going out into the field in.
So that's very different than if someone was being restrained or arrested.
Correct.
Okay. Member Gutierrez.
Thank you, Mr. Chair. Thank you so much for your testimony, and thank you so much for your work. I guess I should have known this, but I was actually really startled by DVH's testimony about the low rate of pay that we were initially offering to people on our mobile crisis teams. And I know that we've made some strides, right, through our joint budget advocacy with Treatment Not Trauma. But I wanted to just get on record, what is the actual starting rate and salary for each role on the mobile crisis team, and how does that compare to other jobs that similarly skilled people might be seeking?
So I'll have to get back to you with the actual numbers on that, and it's also different based on agency. So not each agency pays the same pay rate. JFK maybe being an exception because our staff is unionized, so it's a little different than the other agencies. But a certified peer specialist, the average rate would be between $15 and $20 for a mobile crisis team member, and that's per hour. And for a mobile crisis team member, between about $25 to $32 an hour, depending on the agency. But I can again give you precise numbers once I gather them from the different agencies as well.
I would love to, I think the whole committee would love that information, particularly as we're headed into budget. And what are just I know you have to get us concrete data, and I appreciate that, but do you have an initial sense on how competitive those rates are?
So if we're talking about a master's level clinician being paid, let's go with $30 an hour, it would be about $14 to $15 lower than a comparable job with that, clinical background.
Okay, so that's a problem. I think we can note that. Thank you. And I just wanted to thank Ms. Stewart for the invaluable research that you've been conducting. It'd be great to have a copy of that if we don't already. And I would also say, in particular, I like that you were able to quantify the specific cost saving. I know that, we have a certain number in mind that we're trying to get to for the mobile crisis response in the city, but as a baseline, right, we should at least be, or I would argue that we should at least be adding that cost savings into the budget, because clearly this is a good return on investment for the city. Did you want to respond to that?
Of course. I'm just really thrilled with your focus on the low salaries. We do not pay for mental health in this country, and that goes all the way up to the low reimbursement rates from Medicaid. And so this affects everything from the salaries to what our providers can pay for to salaries at Penn Medicine and psychiatry. It all goes back to these terrible reimbursement rates that happen in our country. The second thing for mental health, the second thing I really wanted to add as part of our evaluation is we're doing a workforce survey. So we've partnered with DBH IDS, and we are almost finished collecting data. We have data from over 230 first-line crisis workers, and so we've asked them about a variety of things, including their psychological safety and also their satisfaction with various factors in their position, including obviously compensation, but also the sorts of supports that they receive. We've asked their satisfaction and then also how important they rate these factors in their jobs. I mean, many of these individuals do not go into these jobs for pay. But then we also ask their turnover intentions, and then we're going to try to follow up with them in 6 months and then see how they rated these factors and whether they have turned over and where they're leaving. One of our hypotheses is because they are receiving better rates in the private sector, particularly with all these telehealth startups, that many of our workforce in the public behavioral health system are moving out into the private sector for better rates of pay and for other reasons. But anyway, stay tuned. The data are going to be almost completely collected in the next week or so, and so we'd love to be invited back to report some of those findings to you.
We would be highly interested in that. Thank you so much. Thank you, Mr. Chair.
Thank you, member. Dr. Ahmad.
Thank you so much. This was really important testimony from all of you. I have a question for JFK Behavioral Health. You mentioned cultural competency. I just wanted to know, we have diverse communities living here with language access issues. Is there something you are doing? And I don't know if it's just you as a provider, and this is something probably, if this is a standard requirement of all providers to be able to bring services that could help in the cultural competency of addressing the needs of the client.
So I'll start by saying all of our teams have access to interpretation lines, but we also will work collaboratively with the other agencies. So maybe there might be a team that's more appropriate for the given call than another team. So then we might not prioritize rapid response time. We might prioritize having the more appropriate team go out and respond. So let's say there's a Spanish-speaking team while another agency doesn't have a Spanish-speaking team available. We might prioritize that in a situation. And I'll let Tanera speak towards training since she conducts the trainings.
Thank you.
We try to make sure that all of our team members are aware of the different cultural aspects in our city as well as their traditions, so they can assist all of these members within the confines of what works for them versus what they may think work.
Thank you. Yes, I think this would be great, and I'm speaking to the previous panel as well, to have this as a requirement in training for those who provide these services to see what exactly they're doing. The language lines that you mentioned, the interpretation lines, they can be extremely spotty in their quality. I've tested it with speaking a different language and what exactly gets said. And so I just worry about quality control there and depending on it so much, whereas if it was more built in, knowing our city and knowing where geographically we have diverse communities, just building that into how we address it would be really helpful and useful.
And I will to speak to that. Because we do have more agencies and because we can spend more time with the consumer, there are instances where we do harness the natural supports. So we might ask a family member who is down the street to come over to help assist us. And that really can, make things more familiar and more comfortable because, as you did say, using a language service line isn't ideal because it's also strange to have someone on the phone while you're both in person. So I do understand that.
That's right. Well, thank you. I just wanted some more focus on that across the board from everybody. I had a question about your response. You said that you were able to avoid so I'm just trying to understand how you respond. For that person from the personal care facility, they called 988, and then how did that happen? How did you get that call versus sending another team? I just wanted to understand that process.
So they called 988, so the service provider at the group home called 988, and then PCL, or the Philadelphia Crisis Line, fielded the call, and then they dispatched JFK based on geolocation technology.
Because I heard you say you didn't have to use the crisis response team. Aren't you the crisis response team? I was a little confused with terminology, maybe.
Oh, so it's the crisis response center. So they didn't have to be transported.
Yeah. So it didn't go to the crisis response center, it came directly to you.
Well, it didn't. The team went out and they were able to have a stabilization plan, so there was no need for the team to transport the individual to a crisis response center for a higher level of care.
Okay, but the responses from whoever can respond, it comes through 988, it's just streamed to whoever is available or is appropriate for responding. I just wanted to be clear about that. And going to the question about salaries, and it's a cultural shift in our country, not just locally, but we need to keep talking about it so people understand what the value is of what the service is and why it's important to reimburse and at a correct rate, at a better rate. And that's where I think all of us can be involved in being advocates for talking about that. So please feel free to reach out to us, to me specifically, because I'm the chair of the Public Health and Human Services, and I think it behooves us to really amplify the fact that we need people ready, well, with good salaries, with the state of mind in order to be able to do this work, regardless of what training they have, right? It's the work conditions we're talking about. So please use us outside of just budgetary concerns to amplify this and lift this up, because we can talk to, even if the federal government doesn't listen to us right now, we can talk to our state level places, particularly the governor, to say, how do we backfill some holes that might be left, and how can we be an example to the rest of the country about what we do for our providers. So we'll look for that. Thank you.
Thank you, member. That's very important that we maintain adequate and appropriate salaries so that we don't have this turnover problem. You are trained professionals, and all you have to do is, even in this building, when we deal with constituents that in our office sometimes will have a crisis, it lets us know how difficult that can be, how traumatizing it can be for us to have to kind of address that without you. We don't know what we would do. And I've had those kinds of situations, and I'm thankful for being able to call upon professionals that can tell us how to intervene, and it resulted in crisis identification for my staff, that if somebody's having a problem, how we should approach it. So thank you for what you do. Chair recognizes Member Harity.
Thank you all. First off,
Hit your button.
Chairman. I have just a couple quick questions. First ones are for Penn, and then I got a couple for JFK. But so Penn, if a family needs mental health intervention team to assist with a 302 of a family member, what options do they have as calling a hotline rather than the 911 system? And if the family member is if the family member is hard to manage or difficult, like what are the options when it comes to somebody, a child or a son, whatever, living at home, and the parents are scared, like we've seen what happened, and we had that tragedy. What options are there? Because I'm a firm believer in, when it comes to mental health episodes and domestic episodes, the police showing up always escalates everything. So could you just tell me a little bit about how that goes and how you guys interact with the family members to help them to get the other family member into care?
I'm going to defer to the clinical expertise at
Okay.
the table.
So there are a few options if a family is pursuing a 302. So perhaps if there's an acute crisis happening in the home currently, another family member who has seen the behaviors within the past 30 days could go to the CRC and file for a 302 petition. The other way is, of course, calling 988, having one of our teams go out. And because we are teams of two, this allows us to maybe separate, the family member from the consumer in crisis. So a team member can consult with the consumer in crisis while another team member gathers information for a 302. Other situations we have is sometimes it's difficult if someone goes to a CRC filing for a 302, it's difficult for a delegate to tell if it's truly a mental health crisis. Because some people don't understand what the criteria for a 302 are. And in those circumstances, they will send out the mobile crisis team to be the eyes on the scene to understand, okay, is this just a situation where someone wants to get someone out of the house, or is this a substance use issue, which, of course, substance use and mental health and a 302 can go hand in hand, but sometimes families really want to force treatment upon people by going the 302 route where it's not appropriate. So these are really the options that are available, and of course the hope is that if someone does call 911 that it'll get patched over to 988 if it's not a circumstance that necessitates a law response.
And since we're on that, just a little follow-up. What is the percentage of what's your rate of you getting there and actually having to 302 somebody or getting them to voluntarily go in? Because it's very different.
Yeah, so about 80% of our calls result in community stabilization, and I would say anywhere between, it's probably about 15% that do result in a 302. And what we also
Excuse
do...
me. For the listening audience that may not know what a 302 is, could you?
Yes, a 302 is an involuntary commitment. It's a warrant for involuntary commitment. And so about 15% might result in a 302, and we also do track on our end the amount of 302s that are upheld once they do go to the CRC, and typically I would say 95% are upheld, and there's about 1 or 2 that are discharged. So it's a pretty high rate in terms of the 302s that are written and the 302s that are appropriate. So about, like I said, about 95%. Does that answer the question? Was there anything I missed?
Yeah, I appreciate that. And while we're on the subject, how do you distinguish with the, as you said, somebody who is suffering from substance abuse and somebody's calling about mental health, knowing from experience, somebody can have a substance abuse problem and still be having a mental health incident rather than it could be caused by the substance abuse, but they're so intertwined, you know.
So the differentiation is really what we would say that the qualifiers are for a 302. So if someone has a substance use issue and they're not caring for themselves, they've lost 10 pounds in the last few weeks, they might have defecated on themselves, they might not be oriented to person, place, or time. These would be factors that could add up to an inability to care. But there are people that are using substances that aren't really, they're not showing signs of mental instability per se. They're using substances, they don't want treatment, but they're still caring for themselves in some way. They're still oriented to time and place. They're not a harm to anyone else. I mean, certainly using substances can be a harm to yourself, but that's not, active suicidality. So those are things we consider when deciding whether it's strictly substance use or it's substance use with a co-occurring mental health issue.
Are there any numbers or studies on whether or how many mental health issues we're getting in different areas of the city? Are there hotspots, in other words, in reference to, since like we brought it up with the Kensington thing, you know what I mean? Is there areas of the city where you see more of this happening? And is that because the substance abuse issues also?
So we do have that data. That data is provided to us by DBH on a monthly basis that we review. So they do have a heat map that shows us the high volume areas, which one of the high volume areas is, the Southwest region, which would be the concern about consortium, the 19143 area code.
Wow.
But we do also get data on, what percentages are substance use, what percentage are psychosis, suicidal, homicidal. So we do track all that data. I don't have it with me on hand, but we get it monthly from DBH IDS.
Okay. Can you guys see in those numbers any disparities in low-income areas? So mental health, right?
Yes, there's definitely a high degree of disparity. I didn't mean to laugh or anything, but a high degree of disparity between lower income areas and higher income areas. I, again, don't have that exact data with me, but we do have it from DBH IDS, which we can be more than happy to send to you after this session.
And does that have anything to do with the amount of care in those areas also? Are they underserved is what I'm trying to get at. Should we have more mental health people in certain areas of the city for different reasons?
Yeah, so access to services is a real hindrance. I mean, as I maybe mentioned earlier, wait times for, let's say, case management could be up to 3 months. And case management can provide services for employment, transportation, medication management, because a lot of these individuals are experiencing crises because of social determinants of health. They don't have stable housing. They're experiencing food insecurity, any number of these things. And so this is something that could be resolved if we had more case management access, really. So I think that would be something to consider.
Thank you so much for your testimony, and thank you for what you do. One of you said earlier, which struck me, which I always say about different jobs, that people that get into this don't do it for the pay. So I thank you. We have a couple of groups like that, police, fire, our emergency responders, and also our social workers and mental health professionals. So I thank you.
Thank you, Member. Yeah, those were good questions and stimulated other questions. Member Goodyear.
Quick point, just following up on my colleague. I haven't seen the map, but I imagine if there were a map about where you're doing the most service calls, that it's the same map of where the most gun violence happens.
Exactly.
It's the same
That's
map
what I was
of
trying to
where
get at.
the housing crisis is most impacting people.
Yeah.
It's the same map of where we have the most quality of life concerns. I'm imagining that all of these things tie together. And maybe, assuming research is not dead in the United States of America, maybe that's the next research study, or maybe it already exists. Thank you, Mr. Chair.
Yeah, that did spark the connectivity between other social issues and this issue. And so if you can provide a map, I think it'll be telling to what is happening. And Member Nina Ahmad.
Just a comment on how to separate what is a mental health crisis because of certain social determinants of health versus somebody who has a mental health disorder that is most likely of a chemical basis, right? So how do you parse that and the data that was just asked for in terms of the overlay of where you see this? We have to be careful that we don't conflate these two things, right? So I just wanted to make sure that the response that you all are giving can separate that out.
So in the guidelines, or I guess it's the guidelines for crisis teams, they did implement a social determinants of health assessment in June of 2024. So that is one of the assessments that we conduct, so we can see clearly what someone might be lacking in a situation. We also conduct risk assessments, and because we have the time to spend with individuals, we also get their information in terms of what their mental health diagnosis might be, what medications they're taking. So we are pretty thorough in being able to understand what is mental health related, what is substance use related, what's social determinants of health related, and what's, a combination of these factors.
Thank you.
I would also, for the record, like to acknowledge President Kenyatta Johnson is here. Would you like to say anything, Mr. President? No? Okay. One other quick question. When you're doing this mapping about poverty, or when you're doing the demographic analysis versus young people versus seniors and the like, can you add members with language issues and cultural issues? There's a difference between certain cultures and how they deal with mental health issues, whether it's Islamic, whether it's Asian. There's a different kind of acceptance, if you would, and if you can kind of asterisk that in the map to the degree that you can.
So I will ask DBH IDS to do that, because we don't generate the reports, but certainly JFK individually, we do track that information personally.
Okay, thank you. Yeah, President Johnson has a question.
This is more geared toward DBH IDS, if that's okay. I know that there will be a transition with the consortium. The consortium is the primary organization that has been engaging in mobile therapeutic crisis services throughout the city of Philadelphia. And so now that there will be a transition, I just want you to go on a record and tell me, what does it look like in the future if we're not using the consortium?
Can members please come back to the witness table? Thank you so much for your testimony. It was inspiring, actually, that we can actually move things in the right direction, but we're going to keep it moving by way of supplementing and dealing with the income issue. To Member President Johnson's question, please.
Yes.
State your name again for the record.
Dr. Marquita Williams, Interim Commissioner for the Department of Behavioral Health and Intellectual Disability Services. Good afternoon, President Johnson. It has not yet been determined that there will be a transition, but in the case that that would happen, we have been having meetings around looking at providers in the area that we could transfer services to, making sure that there's continuity of care, making sure that the level of services that consortium provides would be accommodated for all of the clients so that there's no delay or gap in services.
I just want to go on the record because I know the work that the consortium has been doing. And this started when the young man was murdered by the police officer in West Philadelphia, and then we take a proactive approach in working with the Philadelphia Police Department, making sure we have the mobile crisis units on the scenes anytime that these types of incidents take place where a person is shot and or murdered or having an episode, so to speak. But because I have a large constituent base that utilizes the support from the consortium, and when it comes to this particular topic, I just wanted to make sure that whomever the provider will be, this still becomes a priority. But most importantly, we even talk about expanding it and taking it to the next level when it comes to issue addressing trauma and support for those most in need. So thank you. Hopefully you'll become permanent one day. I appreciate your hard work and your dedication and your leadership. Right.
So that you know, Mr. President, we have been on top of that issue and kind of wanted to not do it here.
Yes.
But we are cognizant of what the issue is for the only minority provider of these services that we know of. So we're on it, sir.
Thank you very much.
Absolutely. Your concerns are our concerns as well. So thank you.
Thank you. Thank you, Mr. Chairman.
Thank you, Mr. President. Without any other questions, did you have any? Without any other questions, thank you all for your inspiring, again, testimony. Ms. Stett, who is the next panel to testify?
Stephanie Bay.
Is that it? Yeah, call up everybody, because we have a hard stop at 1.
Julia Lyon.
Thank you for your patience. Please be seated and begin your testimony.
I'm glad Council President is here so you can hear the hard work that the City of Philadelphia employees are doing. Good afternoon.
Good afternoon.
My name is Stephanie Bay. I work for the City of Philadelphia. I am a program analyst I'm a health program analyst supervisor for the Department of Behavior Health. I've been there since 2008, so I love my job. I am also a member of District Council 47, Local 2186, which represents white-collar supervisors. And I represent the executive board, so I'm an executive board liaison. Although I work in our infant and toddler early intervention unit, and I did bring some resources that our commissioner spoke of that we share in the community, that you can share with your constituents, that will help you understand the services we do provide, and I'll make sure I get that to you. Although I am with the union, and I work in the infant and toddler early intervention division, as a liaison for the executive board, I also meet with our members. So I'm going to present the voice that our members are not being presented with today. And we are the Philadelphia Crisis Line. We are the ones taking it. We are the frontline workers. We're the ones receiving the calls, and we're the ones dispatching it. And here's what they have to say. Good afternoon, Public Safety and Public Health Joint Committee members. A special thank you, Councilmember Curtis Jones, for providing a space for us to share insight on the mobile crisis team structure and crisis response process for the Department of Behavioral Health, Intellectual Disability Services, affectionately known as DBH-IDS. The 988 Suicide and Crisis Lifeline offers 24/7 access to compassionate, trained professional callers experiencing suicidal feelings, substance use challenges, mental health crisis, or any other emotional distress receiving counseling, guidance, and direction for prompt evaluation and treatment services. 988 serves as a universal entry point nationwide, ensuring that no matter where you live in the U.S., you can reach out to a trained counselor for support. The Philadelphia Crisis Line have a unique in-house model. The Philadelphia Crisis Line, affectionately known as PCL, is the only in-house crisis line in the country. Let me repeat that. We are the only in-house crisis line in the United States of America. Unlike others, cities where crisis lines are contracted out, having an in-house system is more efficient and cost-effective. Mobile crisis team, they're also known as MCTs. Each mobile crisis team consists of nurses, master-level clinicians, bachelor-level mental health workers, recovery specialists, and certified peer specialists in some cases. Team members receive training through their respective organizations, along with additional training provided by the Department of Behavioral Health Intellectual Disability Services. These include, but not limited to, 302 training, which is the involuntary committed process, mental health first aid, and dispatch system operations. This is what we do, and we continue to do to support those that support our families. All team members are required to complete yearly training and to maintain expertise and effectiveness in crisis response. And Councilman, I knew you wanted to know the process of what happened when the calls come in. The crisis response process and timeline. An individual in crisis can call 215-685-6440, but that may be too much. Or you can dial 988, which is simpler and easier, right? The Philadelphia Crisis Line staff answer calls and communicate with the representatives to gather details about the person in crisis. This is what we do, your employees, City of Philadelphia. This is what we're doing. A dispatch is sent to the closest mobile crisis team, and you heard that they are broken down by regions. There are separate teams for adults and children. If the team determine that the individual meet the criteria for assistance, they help family or friends draft a petition statement if voluntary intervention is needed. If the individual is willing, they are transported to a crisis response center, and I have that information. Our department has it on our cards that I will share with you. And response time varies based on the individual's cooperation and situation specific. Additional follow-up team and care coordinators help connect individuals and families to person-centered resources for ongoing support. What are some of the opportunities for improvement with our mobile crisis team? We believe the mobile crisis team could benefit from a centralized training program for all team members, including the supervisors and administrators. Mental health workers, which are the bachelor level, mental health workers often struggle with identifying and diagnosing and should be equipped with broader range of options for support for the individual in crisis or the family. Some individuals may not require hospitalization, but simply need guidance or someone to talk to. Furthermore, Philadelphia Crisis Line operate with one health program manager. This is a 24-hour shift. We have 4 supervisors and 10 to 12, I'll say, social workers that are taking these calls. Although our leadership is aware that there is one health program manager, they are working with him to build capacity, and congratulations to him, his wife just had a baby. And our supervisors say he does get on calls with them 2 o'clock in the morning doing the supervision. But we need to build capacity within, okay? We want to talk about that. And overseeing off shifts, this leaves overnight staff with little to no direct support. So what do we do as supervisors if we're in crisis 3 a.m. in the morning? We have to reach out to the manager. And he has to be back on the following shift. We have 4 shifts. So as we're looking to build capacity for the mobile crisis team and bring in resources, we want to look at building capacity for the civil servants, that, because he's a civil servant, our health program manager, to build resources to support him. And the union is, we understand that he needs additional support, but that's a lot to work 4 shifts and manage all the numbers that you heard shared. That's just a lot for us. Okay, so DBH Mobile Crisis Team Provider, we have PATH, which is Region 1, that is the Northeast. We have JFK, which is Region 2, North and Center City. We have Elwyn, they are Region 3, North and Northwest, and the consortium is Region 4, South, West, and Southwest Philadelphia. We do have a Children Crisis Mobile Team. I didn't hear them spoke of often, but it is called Children Crisis Treatment Center, and we know CCTC. They've been around a very long time. And I want to take this opportunity to thank all of you for your ongoing support and dedication to improving crisis response services in the city of Philadelphia. And that concludes my testimony. Thank you very much.
Okay, we're going to hold questions until the
I agree.
entire panel testifies. Is anyone else? State your name, please.
Hello.
Thank you for your patience.
Of course. Hello, my name is Julia Lyon. I use she, her pronouns, and I'm a licensed clinical social worker and a therapist, and I work in Center City, Philadelphia. I've worked in community mental health, which means mental health services that are funded by Medicaid or for those who are living in poverty, in Philly for 11 years. For the last 4 years, I have been a member of the Treatment Not Trauma Coalition, or TNT, a community-based group which formed after the police killing of Walter Wallace Jr. in West Philadelphia in 2020. I'm here today to share with you some of the truths that I have come to learn in my work over the last decade, and I'm here to implore you to invest in the expansion of CMCRT, the Mobile Crisis Program, which is a common-sense, life-saving solution to mental health crises in Philadelphia. The first truth is that people experiencing mental health emergencies are at their most vulnerable and are in a state of powerlessness. Because of this vulnerability, these folks need a response to their emergency that is safe, timely, and clinician-led. The second truth is that when people don't have this kind of response, they suffer. I have seen it. 25% of all fatal police shootings involve a person with mental health problems. The third truth is that that kind of suffering and loss is completely avoidable. On countless occasions, I have seen my clients become endangered by the wrong response arriving on scene. And conversely, I have seen how connection, support, and therapeutic intervention can change the course of someone's life or even save it. CMCRT is the best tool we currently have as clinicians, as family members, as neighbors, as Philadelphians, to support someone who is at the point of a crisis. CMCRT stands uniquely apart from PPD's CERT or co-responder program. CMCRT fulfills an urgent and desperate need that was previously completely unmet in our city. CMCRT is the difference between finding a way out of a crisis and nothing. It is the difference between a hand reaching out for help and a gun being pointed. It is a lifeline. As a clinician, I cannot begin to tell you the value that CMCRT has had for me when helping my clients and their families plan for their safety and well-being. As a neighbor, I cannot begin to tell you the value of having a service to seek out for people who are visibly in need, in distress. As a former school employee, I cannot begin to tell you the value of having a team to call that can give the child in front of me the chance to feel safe and to begin to heal. However, this program is not nearly big enough to meet the current demand of our city. CMCRT needs to be scaled up to meet that need. Average wait times were over an hour for the first 3 years of the program's existence. This needs to be reduced to 30 minutes or less. CMCRT teams need to be able to get to their clients quickly, efficiently, and without traveling across the city. Philadelphians need an easy-to-remember and clear way to access help in a mental health emergency, not a jumble of numbers, acronyms, and departments. I safety plan with my clients all the time, and almost all of them don't know that CMCRT exists. Folks need to be able to navigate these systems without any expertise or insider knowledge or the advocacy help of someone with credentials. Community members need to be made aware of this program, how it works, and what decisions are being made about its design and its implementation. Community members need a response that is not police. CERT and programs like it, the co-responder model, dispatch a police officer and a clinician, and this response boils down to another police response. The presence of police makes people feel unsafe and makes de-escalation, connection to support extremely difficult, if not impossible. I have witnessed this myself many times. Mobile crisis funding and resources should go to clinician-led programs like CMCRT that result in better outcomes, like fewer 302s, and cost less. Finally, the most important truth that I know, the one that has been shown to me over and over again, is that humanity is fragile. Humans can only thrive and indeed survive when another person with some expertise or some compassion is available to help. We would consider it barbaric and strange to expect a person having a heart attack or a person whose home is on fire to somehow find a way to change their situation on their own. We would find it strange or barbaric to say, oh, I'm sorry, we don't have enough funding for the program that dispatches someone to support you if you have a heart attack or your home is on fire. We have all seen people suffering but thought it would be too hard or too uncomfortable to help. Recently, we have seen dehumanization and cruelty everywhere in our country and at the federal level. Today, I ask you to put the necessary resources, money, and attention into a program that works, that people can rely on when things are too hard and when people are in desperate crisis. We are beyond the exploratory phase of mobile crisis planning in Philadelphia. A clear picture has formed of what works and what doesn't. A clinician-led response works, and a police-led response does not and risks violence. There is a need to take action now to save lives. I ask you to fully fund an expansion of CMCRT, to keep your attention and eyes on the program and its growth, and to offer your support to those who implement it. I ask you to do all of these things so that when one of your neighbors or someone you love is utterly alone, there is someone to call to come to their aid, to your aid. Thank you.
Thank you for your testimony. Well said. You're not speaking today? Is that okay?
Yeah, I'm just here to help support. My name is Robert Harris. I'm the Vice President of ASME District Council, to support with any questions, but we put everything that we needed to say in our members' testimony here, and next time we will have call center folks. They are very hard to come by. They are working many hours, so we will have them for you next time.
So for me, as I turn it over to my colleagues, one suggestion, and I heard several, but one suggestion you would emphasize to make it better for people in Philadelphia.
To me?
Yeah.
I would
go this way, yeah.
Many things. Number one, I would say to just push DBHIDS and city infrastructure to expand as quickly as possible. I know that last year for our budget demands, TNT's recommendation was an immediate doubling from roughly around $10 million to $20 million in order to just immediately give those 4 provider agencies more money to hire more folks, just to meet demand. So that would be, to me, the immediate and the most important thing. I think people like this program when they utilize it. I think it is a much, much better option than people calling 911. I think also just bumping up awareness of the program as much as possible. I cannot tell you how many times people have told me that they endured unnecessary suffering or risked losing themselves or someone they love to suicide because they were too afraid to call 911 and have police officers respond. And I want people to, I know that CMCRT and PCL are not perfect, but I don't want people to be in that kind of anguished decision any more than they have to be. So I would say for me, those are the 2 biggest things. Just rapidly expanding as fast as is feasible with the 4 agencies that already have contracts, and then to just consider scaling up the program. Additionally, long term, I think it would make sense for people who staff CMCRT to be city workers, to have even more of the infrastructure housed within city in addition to how the PCL is. I think this makes sense, and I think that it would provide a more stable long-term structure to avoid sort of rapidly changing funding streams and kind of shifts in policy choices based on political administrations.
Good response, but I did say one thing. You mission creeped all the way to all things. Thank you, though.
It would be, I don't know if my mic is off. Is it on? Okay. We would say across system training. One thing about DBH, Department of Behavioral Health, Intellectual Disability Services, we are a heavy community-based department. We work in collaboration with many community partners, and we do a lot of community outreach. We do a lot of educational training and involvement. We even open ourselves to train the community. So if we can continue to do training across systems and also with our community partners and with the community. What better is to train a parent of the child that's presenting with the issue? And this was previous Dr. Evans. I don't know if you remember Dr. Arthur Evans. His vision was treat the neighborhood. You can't just treat the individual. You have to treat the community, and that's when we opened up to do training everywhere. So my commissioner, my leadership is right there. We go everywhere. We don't care. We're in every emergency and transitional housing. We don't say shelters anymore. That's not a nice word. But we're there every day. We're in our drug and alcohol programs every day. We were in the warming systems. We are everywhere disseminating information about the Department of Behavioral Health, Intellectual Disability Services, because we provide mental health, substance abuse, intellectual disability, and don't forget the babies birth to 3, born with medical diagnosis and developmental delays, and that's who I serve.
Thank you. I know you didn't testify. Would you like to give a...
That's good. I get one. I absolutely agree with my sister.
Please say your name for the record.
Robert Harris, Vice President, AFSCME District Council, 47. I agree that we should be bringing these programs into civil service positions, that we've invested into the program. We see that it has done positive things for our city. We see that we are spending our city-owned earned dollars as citizens of Philadelphia. You know, we should make sure that we're getting Philadelphian strong union jobs, that they are working for the city of Philadelphia and doing the services for the members of our community. So we should be working this program not only out into these other aids and contracting them out. We have people to do that here in Philadelphia, so we should be doing that work.
Just for the record, I want to thank you all for educating us, because we learn by having these hearings on how to be helpful. So thank you. Member Gutierrez? Okay. Mm-hmm.
Thanks to all of you for your testimony and for your work as well. My questions are about PCL. First, thank you so much, Ms. Bay, for just describing so comprehensively what the staff are taking on and how great of an effort they're making. You all are helping to save lives and helping people, I'm sure, helping people to feel not so alone when they feel very alone. I also really loved your idea around the cross-training and really getting out more into the community. I honestly predict that as the city starts to feel more of the impacts of what's happening at the federal level to our economy, we're going to need that type of training and support for people even more. I wanted to ask, you talked about sort of the current staff complement and how that is difficult with the amount of calls and the situations you all are taking on. Can you talk more about the staff complement that is more desirable? And I'm sorry if I missed that in the testimony.
Yeah, I don't know if I could talk to that degree because there are members, and they're actually, our members are the supervisors overseeing the staff. So just to answer your question, and I just want to highlight, because there's only one supervisor and 10 to 12 staff person, it's sometimes very difficult for us to take leave of absence or take vacations. These things have to be in consideration. So some of the things that they may be discussing or additional support, is that what you're asking?
Well, you so eloquently outlined why it's difficult to have so few supervisors because you're getting calls 24 hours a day. I wanted to know, and if this is something that the union wants to get back to us about, then that's fine. What would be more ideal with the volume that you have?
Oh yeah, so we would say we need maybe 6 to 7 supervisors, and for the staff that are handling the calls, I see about 15 to 20 because the volume of the calls. And what would happen, it would allow them, because sometimes they call in and our members, our staff, will have to reach out to their supervisors because the calls coming in from the mobile crisis team may not, it's like, oh, this doesn't qualify for 302. So they have to follow up with their supervisors before they deny anything. We have an internal, and I think she's a process in place. We just can't deny 302s. It's a process, and they have to go to their supervisors to seek guidance, right? So that may extend a phone call. So if we had sufficient staff on each shift, it would allow us to prioritize, right? Move it over to the next delegate so Robert could deal with that while I'm working with the supervisor, because I'm not getting the correct information from the mobile worker that's calling in for this 302. So if we could get additional staff, for me, I would say I would love for us to have 3 to 4 more supervisors. I would love for us to have maybe 5 to 6 more clinicians that are taking these calls, or social workers that are processing these calls. I know we're short-staffed. We have our labor management meetings with them. We know that we're short in our positions. It's hard. It's hard, to find staff to backfill these positions. But we have an interim supervisor that was taken away that's acting in the role as a manager. A supervisor acting as an interim manager. But she's a supervisor, but we need help. And our HR is working with them to build the capacity. We also have Deputy Commissioner Amanda Davis that's working closely with the leadership in that unit. They're working with us. So we don't want to present they're not, right?
Yeah.
They're definitely working with us the best they can to help build the capacity. But it's finding the staff, right? It's finding the staff.
Thank you so much. That's helpful. I see DVH chomping at the bit, so I think they want to add into this question. But I want to put one more question that maybe someone could expound upon. I know that we do a pretty good job of tracking sort of what happens when people call 911, right? When someone calls 911, how long it takes for them to get an actual answer. Beyond talking about the staff complement at PCL, if anyone can give information on how long does it take for, if I call 988, for someone to pick up the phone and answer my call.
Yeah, that would be leadership. I'm not familiar how long it takes.
All right, so we got 15 minutes. I got my other members, and then
Thank you all. I have palm cards for you. Am I allowed to give that to you, or can we approach, or no? It's like we're in a court.
Yeah.
Thank you all.
Say it again.
Sergeant at Arms can take her.
Yes.
Okay. Her cards. Oh, but she left. I had a question for her.
All right, all right. Why don't you get your question on the record?
Oh, okay, thank you. I actually had a question from Ms. Stephanie Bay, because she mentioned mental health workers sometimes struggle with identifying diagnoses and should be equipped with broader range of options for support. So this means you're talking about master's level clinicians who should be addressing this. I just wanted to understand the
Those
flow.
are the bachelor level mental health workers. I believe the master level clinicians are the supervisors. I'm not familiar with how they're made up, but I believe it's the bachelor level mental health workers that are calling in when they're reporting to a scene where there's a possible crisis.
So that's what you said. Mental health workers sometimes struggle with identifying. So what would be useful in this?
The individuals that work in that unit, our members are saying they need they need additional training on how to identify diagnoses. Is, what is this something that we could provide resources for? Is this something where they should get a 302? It's like sometime when they're calling them, they're just saying they're presenting with, they're being defiant, they're not being respectful. This is the younger one, right? They're cursing, they're being belligerent, they're giving us a hard way to go. Do we have to 302 this person? Because the mother wants the person out of the home, the mother's afraid of them, they're scared. So they're calling with these diagnoses, right? And I guess sometimes it has our mental health workers struggle and they have to follow up with it has us follow up with our supervisor for clarity and guidance and support in the decision that we may make. So we feel they need additional training that are going out to these sites and doing these evaluations and making a determination on what should happen with Philadelphians when they're presenting with a crisis.
So additional training, and would it be useful to have the people they're asking these questions of with them as part of the team?
Yeah, I'm sorry. I didn't hear you. I'm sorry.
So in addition to additional training for those who are responding, would it be useful to actually have on site with them people who do have the ability to answer these questions, meaning have a broader team address it rather than people with not sufficient training?
And I think what he was also saying is the language, right? We're in Philadelphia. We have different cultures. We have, from what we learned, over 99 or 100 different languages spoken in the city of Philadelphia. And we represent things differently. With me working with infant and toddler, the state mandate, we use family-friendly language. Family-friendly language. We could be very clinician. We can use clinician language, but we're dealing with a family that don't know clinician language, right? We have to meet our families where they are and speak a certain dialect so we all can be on the same page. So that's what we mean by, going out there, having more than one person. You're right, and I believe it's more than one person that goes out. Not familiar, but I think it's more than one person that go out when it's a crisis. And we want to note that City of Philadelphia employees do not go out. Only one that may go out is a manager or a supervisor, but it would be an extreme reason for us to go out. Typically, we don't go out.
So it would be the team, the providers who are responding.
It's the providers who are responding.
I'm just trying to understand where the level of what additional information is, so the team who's responding, the providers who are responding, should have access to somebody who can help them make the diagnosis better, including get a better training.
Yes, to support your
staff.
staff.
Just trying to clarify that. Okay. So will that support come from Department of Behavioral Health and Intellectual Disability Services?
Yes, it does.
Okay.
And leadership here can go into more details, but yes, it does.
All right, thank you.
Thank you, member. Commissioner, you wanted to interject something for the record?
Yes, Dr. Marquita Williams.
State your name again.
Interim Commissioner. I wanted to add some additional information and to address Councilwoman Gaultier's question. Kenny Solanke is going to talk a bit more about our staffing complement as a follow-up to Ms. Bay. But I also wanted to let you know, Councilwoman, that from January 2023 to January 25, we had 147,375 calls. The average call length is 7 minutes, and the average call speed is what you asked for, is 11 seconds.
Thank you so much.
Okay.
My name is Kenny Solanke, and I'm the Senior Director of Crisis Operations. And with regards with those numbers, we have approximately, our staffing pattern is set up to have 43 people. So we have 9 supervisors, we have 2 program managers, and the rest are crisis counselors. We have 6 current vacancies that we're actively working to fill, so we are adequately staffed for now. As we continue to grow the program, our expectation is as we start with chat and text and we do follow up, we're going to see an increase in demand for staff. So the plan is to use the current vacancies, and then if we need more, obviously, we're going to be speaking with our commissioner to see if we can include that in our budget.
Wait, when you say you're adequately staffed, do you mean
for the current call volume?
With the
6 vacancies
filled?
Yeah.
Okay, thank you.
All right, we are at 1 o'clock. I'm going to just put that on the record. Member Harity.
I'm good. Most of mine
You good?
were answered. Just the one, what type of budget number are we talking to fully fund your program?
I'm sorry?
What was the budget number to fully fund your program? You said
So it was
20 million?
last
Oh,
spring, I don't have like the most up-to-date numbers. Last spring, our demand as TNT was just an automatic doubling. That would take it from roughly 10 million to 20 million.
Okay, I got it. That's all I need.
Okay. Thank you so very much for your testimony. Ms. Steck, where are we? Is that good? It's public comment time?
Yep.
All right. Thank you. Thank you so very much. This was informative, and that is the precursor to our budget so that we know how to be helpful. Thank you so very much. Ms. Steck, would you please name the individuals that want to testify?
Nikki Grant, Stephen Strauss, Audrey Houtig, Caitlin Oyer.
For those who have written testimony, please allow the Sergeant of Arms to take it. If you can summarize that testimony, that would be helpful, because we do have a hard stop, which we are already beyond. But that's all right. When you're getting good information, say it again. Yeah. I can't hear you.
Do you want to limit it to a minute?
Yeah, let's do a minute. And if they have it in writing, please submit it. Thank you so much for your patience. Please be seated. And in the order the clerk said, would you state your name for the record and begin your testimony?
My name is Nikki Grant. Good afternoon.
Hi, Ms. Grant.
I wanted to start by saying really appreciated hearing all the testimony today, and I wanted to share that at Amistad Law Project, where I'm the co-executive director, we have a documentary that follows workers from the consortium doing their mobile crisis work. It is almost done, and we will love to have members of council screen that documentary. It's about 15 minutes. I actually am here today. I wanted to read the testimony of a TNT member who was actually going to testify back when this was scheduled earlier last year, but wanted to have her words in this space today. My name is Clarice McCants, and I'm a resident and native of Philadelphia. I'm a mother, wife, help lead a nonprofit here in the city, and I'm also the primary care support for my sister who was in recent years diagnosed with severe mental illness. Over the past 4 years since her diagnosis, I've come to learn more intimately than ever the derelict and soul-crushing conditions of Philadelphia mental health services. What we've experienced while accessing care at every single level, from mobile crisis to crisis response centers, inpatient behavioral health, and outpatient care, has been truly horrifying and traumatizing to my sister. Out of pure and honest desperation and rage, I started going to treatment not trauma meetings, wanting to understand what was going wrong. I want to give you a glimpse into what people are experiencing and implore this body to do everything in its power to make radical improvements to these programs. We need to make sure that the reality that my sister and so many others are facing is no longer the norm, and that people can get the care that they need without hassle or fear for their safety and their dignity intact. Public mental health care is one of the most important ways to ensure a safe and thriving community, and these services need more investment, not less, and that investment needs to come with clear standards of care that improve the mental health outcomes of people who need them. There have been multiple times that my sister was in a mental health crisis and I needed urgent support for her care. None of those times did who and what showed up for my sister help my sister feel safe and cared for. In October 2023, I got a call from my sister while I was at work. She had taken some pills in an attempt to take her life and was now feeling lightheaded and collapsed on the floor while she was on the phone with me. My heart started pounding. I was so afraid. I did not want to call 911, but I knew she needed to get to the hospital immediately. I called 911 and asked them to send an ambulance. They said that since she was experiencing a mental health crisis, they had to also send police, even though I asked them not to, since she was not a threat to anyone, because she was literally collapsing on the floor. She needed medical help, not police. What crime was taking place? So now I'm zooming through traffic to get to her place before the police does, because who knows what's going to happen once they get there. I arrive and they're kicking the door of the apartment, trying to bust in. It's already very escalated. I ask a neighbor if he'll let us up. I'm trying to answer them calmly, let them know I'm on the phone and she's not a threat. Once we get in there, they start yelling and rifling through her things. I'm just trying to keep myself calm and see my sister on the bed laid out and unresponsive. Thankfully, we got her to the hospital safe without incident. She survived. The police did absolutely nothing but make an already stressful situation more stressful. I think it's important to know that a few weeks before that, she was in an inpatient facility trying to become stable during a manic episode, and the experience in that city's mental health system left her traumatized, depressed, and hopeless about her condition. Had she gotten the right kind of care then, she may not have even been in that situation. So Clarice goes on and has more stories about her sister and her experience. She didn't call mobile crisis, and that situation did not actually go very well. So they waited over an hour for help, and then ended up going to a CRC. But I just wanted to share her words, just because these situations are very chaotic, and so we need the system to be as structured as possible, that people who are in crisis can get the help they need without, the police and so on. So that's all I want to share today. Thank you.
Thank you so much for sharing her testimony. And we shouldn't have to struggle between getting help and endangering the people needing the help. And that is a difficult thing to manage, and one that needs classically trained people to be able to do it. Thank you. Next person to testify.
Good afternoon.
Good afternoon.
My name is Stephen Strauss. I'm an urban policy analyst, now retired, having worked for cities, counties, unions, and nonprofits. I'm a member, of course, of TNT. When people experience a behavioral health crisis, they need special care grounded in dignity and compassion. Sadly, police have become the default responders for handling the needs of people suffering under the weight of social issues, from mental illness to lacking housing to substance use, domestic violence, and more. Typical behaviors linked to the behavioral health struggles, like loitering and minor public disturbances, suck people into the system, and for some, it becomes an endless circle of trauma between jail and the streets. Police presence feeds the criminalization of social marginality. Although officers may have some de-escalation skills, their presence alone heightens tensions, especially in poor Black and brown neighborhoods. Research points to the staggering estimates of 25 to 50% of those killed by police having histories of mental instability. When the default response is the police, it not only threatens those in need, it undermines public safety by diverting resources from violent crime. Although the PPD does not disclose 911 call data, which should be public and anonymized, national studies find that most calls sending police have nothing to do with serious crime or violence. But one sector in this depressing story that is a standout is civilian behavioral crisis response units that send care workers only. There are now more than 100 programs across the country, and they're showing great promise. They rarely need police involvement, and they're doing the job at lower cost and more effectively, with fewer involuntary commitments and drop-offs at the ER. If there's a central driver, it's probably the focus on relationship building, especially through staff with direct life experience. Philadelphia is very much a part of this new world, as we've heard, even as some may say or favor a carceral approach in this area. CMCRTs are clearly up and running. Yes, there are also friction points. Philadelphians are unclear about who's coming. Will it be CMCRT or police with weapons and barking orders? Clear decision criteria for triaging at 911, if it exists, have not been disclosed. CMCRT remains starved of funds and in need of structural changes, stability, and community oversight. Most of its caseload is through 988, and according to DBHIDS, as we've heard, few responses require police on the scene. More clarity, however, on the police role is needed. So those are my prepared remarks, and I know it's been a long day. I was wondering if I could briefly answer Chairman Jones's question about what might you recommend. So it's really a kind of a wonky data question, in that we haven't yet really found the full universe of behavioral health crisis responses in Philadelphia. We don't know what that is because we're missing 911 data. We have reason to believe that those are the bulk of the calls, certainly more than any other single categorization, right? It's police who are answering those calls. They may be trained in some sort of intervention procedures, but we have no idea really the numbers, although we got a hint of it for, I think, 2021, and the numbers were quite astonishing, something like 1,500 calls per week. Now, we need an update on those numbers. I'm not even positive that that was the figure, but it was astonishingly high. So to understand the mental health situation in Philadelphia, we need to figure out what those are. Thank you.
Thank you for your testimony. I heard nods of approval and appreciation of what you said. So thank you.
Good afternoon. My name is Audrey Hausig. I live in 19143, and I've been a music therapist here in Philly for 25 years. I've been extremely privileged to have thousands of people tell me about themselves, about their worst times, about their stories. And I've worked residential, outpatient, and inpatient. And something I wanted to share about inpatient is that when we do our treatment groups, I can't tell you how many times that instead of talking about our goals and objectives about gaining coping skills and figuring out triggers, that we're stuck on people being activated by the guilt, the shame, the fear, and the trauma they experienced being handcuffed and brought into treatment in a police vehicle. So we never even get to the symptoms or what's really going on that brought them there. We spend most of the time just providing support to help people stabilize and start to work through their experience of the transport into the hospital. At the hospital, when there is a psychiatric emergency, they generally don't allow security to be involved, right? Because that scares people. If you think of your most fearful, awful moment, do you want flashing lights and handcuffs and someone with a gun, right? Or do you want a clinician or a peer specialist who understands what you've been through? So even with my master's degree and everything I've learned in my presence, if I came in a police vehicle with that uniform and a gun, I'm not going to be effective in de-escalating people. So I just want to implore you to increase mobile crisis so that it's available to everybody of all ages, including youth, to adults, so that people can feel safe and people feel confident reaching out. Because right now, a lot of folks won't call because they're afraid that police will come and they'll have more harm done than good. Thank you.
Thank you for your testimony. For those people, can we transition them to the table? And thank you again for your brevity, and thank you again for your patience. We appreciate it. So why don't we go from your left to my right, I guess.
Yeah.
State your name for the record and begin your testimony.
Hi, my name is Caitlin Orner, and I'm a business owner in Germantown and a member of the Treatment Not Trauma Coalition. As a business owner on a prominent commercial corridor, I've encountered a number of mental health crisis situations ranging in intensity and outcomes with a variety of responses from both PPD and other providers. I got involved with TNT after a number of failed responses from PPD, most notably when I viewed on my surveillance footage a woman in crisis encountering 2 Philadelphia police officers, and after a few moments of dialogue between the 3 of them, the officers got back into their vehicle as she lay down in the intersection in front of my shop. The officers drove away as she lay in the street blocking traffic. She was struck and killed in the same position a minute and 30 seconds later. Her death could have been preventable had the officers taken the necessary precautions to assist her in that moment. Her death could have been preventable if there had been access to a timely mental health response. Her situation deserved an immediate response from specifically trained mental health professionals, not law enforcement, who may have given more of a response to a fallen tree limb blocking the intersection than they did to a literal human life in the same position. High-stakes situations such as these deserve immediate response time 7 days a week, 24 hours a day, including midnight on a Saturday night in the middle of a holiday weekend. As a business owner, I've continued to witness additional crisis moments and have struggled to find appropriate non-police responses to those situations in the moment, which has sometimes led to police being dispatched anyway, or more commonly, nothing at all. Recently, our business neighbors attended a small business roundtable with Councilmember Landau, and they echoed this similar sentiment and its effects on small businesses. We are often the institutions interacting firsthand with community members in need of assistance on a daily basis, but lack resources to provide safe alternatives to their circumstances. As we continue to see a rise in mental health crises, I'm hopeful our city can adapt to respond to the growing need in a safe and dignified way that decreases law enforcement response and increases skilled professional interactions and non-traumatic interventions that result in fewer deaths and a more positive outcome for all. Thanks.
Thank you so much.
Good afternoon. My name is Jenny Zhang. I'm a Philadelphia organizer with Asian Pacific Islander Political Alliance. We're a statewide Asian American advocacy organization. I'm speaking today in support of fully funding our mobile crisis units here in Philadelphia. Today I wanted to share the story of Christian Hall. Christian was a Chinese American teenager, and he was experiencing a mental health crisis in Monroe County in Pennsylvania on December 30th, 2020. He called the police because he needed help. The Pennsylvania State Police responded by shooting him 7 times. Video evidence shows that Christian had his hands up when the police opened fire. A call to 988 and access to mobile crisis units would have saved his life if his mental health crisis was met with a mental health response and professionals. Christian might still be with us today. This is not the first time you all have heard his story. Last year, City Council passed a resolution honoring the life of Christian Hall and advocating for full funding of 988 at the state level. So hearing everything today and knowing Christian's story, you all know how important mental health response is to a mental health crisis. And mobile crisis units could have saved Christian's life. Mobile crisis units could have saved Walter Wallace's life. And mobile crisis units have saved lives already, and if fully funded, can save many more lives. And especially as Council considers the budget and as we face potential federal cuts, we cannot afford to skimp on life-saving resources and services. It is now more important than ever that we fully fund culturally competent and linguistically accessible mental health services that protect the health and safety of Philadelphians. We need and deserve compassionate professional mental health response to mental health crisis. Thank you.
Thank you. I remember that resolution and the sadness in which we submitted it. I think we have 2 other people to testify. Is that right, Ms. Stack?
Yes, Max Osborne and Terry Rayner.
Thank you so much for your patience. Please be seated. State your name for the record and begin your testimony.
Hi, my name is Max Osborne. I am Assistant Professor of Sociology and Criminology at Villanova University. I'm also a member of Treatment Not Trauma, and I also am a resident of the 19143 zip code in Southwest Philadelphia, which, as we've already discussed, is the zip code that is currently utilizing mobile crisis services at the highest rates. So I'll be brief, and I don't want to recap too much of what people have already said, but I'm also asking that the city invest further in CMCRT as the most effective common sense solutions to crisis response. We know, again, that about a quarter of all police shootings involve civilians with mental health conditions, and that about 2/3 of police shootings of people in crisis are fatal. We also know that these harms are not distributed equally, and that people who are disproportionately likely to be killed or harmed by police include Black and brown people, disabled people, and queer and transgender people. These disparate impacts mean that comprehensive non-police response options are especially important for protecting our most vulnerable community members. I also know from my own research, which deals with service access and crisis response for marginalized populations, that when people have negative experiences accessing these services, it really deters them from accessing them in the future. I have spoken with people who have had non-consensual police involvement in response to crisis situations, who have had involuntary hospitalization experiences, and who have told me point blank, I am never going to feel comfortable asking for help again. Like, I am never calling a service, I'm not calling a hotline, I'm not calling 911, I'm not calling 988. I do not feel comfortable because the experience that I had was so traumatizing. And so I do want to just note that this is a compounded problem, right? It's not just the response in the moment, it is what messages this sending to people about what is likely to happen to them if they ask for help from these services. When I've asked people in research interviews, what would you, in an ideal world, imagine happening to you in a crisis situation? What resources do you want to be available? The number one most consistent response that I have heard is that people want some sort of middle ground between calling 911 and doing nothing. Right? They want help, they want services, but they also want to be assured that police are not going to show up unexpectedly. Because people are very, very concerned about that, and people who are experiencing crisis themselves or are witnessing someone else in crisis are forced, as other people have mentioned, to decide between potentially calling 988 or 911 and having police show up and harm their loved one, or doing nothing and having the loved one harm themselves or someone else. So it is really an impossible choice, and too many people are forced into that situation. So as other folks have said, CMCRT seems to be the best tool that we currently have to support people in times of crisis, without involving police, without involving coercive responses that cause people further trauma and victimization. So I, like the other Treatment Not Trauma members, I am asking that you commit to protecting our most vulnerable community members by expanding and fully funding CMCRT. Thank you.
Thank you for your testimony, and I sense that this process is evolving, that with your testimony, with other testimony today, we're hearing it and seeing how we can tweak it for the better. So thank you for your testimony.
Thank you.
Please proceed.
There are no further speakers, Mr. Chairman.
Did we miss someone? They weren't here. Oh, okay. I'll tell you this, and thank you, members, for sticking it out. I do appreciate it. But what we heard was encouraging. What we heard was, and imagine this, because I've been around a minute, actual public policy that is actually improving things. That is refreshing to me to see that, no, it is not perfect, but yes, it is moving us in the right direction. And that with that input that we received today, we might be able to tweak it and make it better, whether it's how we compensate those individuals, those highly trained individuals that provide this service, to designating them as first responders, to being able to increase the amount of responsiveness, meaning cutting it down to 30-minute response as opposed to what is a 50-minute response. All of those are worthwhile goals. And the only reason we know these things is because we listen to the people who have to do it. So I applaud you all for caring. And with that, my co-chair, would you like to say something? Or anyone else?
I just wanted to thank Councilmember Curtis Jones This is a joint hearing, but he's the impetus for this. So I'm very grateful to him for bringing all of you here so we could learn from you. We could see what the progress has been made and where we need to improve. And I know there's going to be more follow-up and follow-through. I want to thank all colleagues here who are members of either both or one of the committees. And as Councilmember Jones said, if we don't do this, if we don't listen, we're not really serving our constituents. And this is why this is so valuable and worth us sitting through it. And thank you all for coming and participating.
Anyone else to? Okay, with that, this concludes the business of the Joint Committee on Public Safety and Health and Human Services to review resolution number 240703. Thank you all for attending.